مع محاضره استاذنا الكبير استاذ دكتور ماهر بيه العسال. اتفضل يا استاذنا.
العفو يا حبيبي، ربنا يكرمك.
العافيه يا استاذنا.
ماكسمايز بقى.
اتفضل يا فندم.
بسم الله الرحمن الرحيم. Many thanks to my dear friend Professor Muhammad Jamal Al-Ashhab, Dean of Faculty of Medicine of Benha University, who is fixing this nice meeting, and many thanks for the invitation. Mr. Chairman and dear colleagues, my topic is avascular necrosis of the shoulder. Avascular necrosis is loss of blood flow to the bone, leading to death of bone cells. The intended learning outcomes of this presentation, or ILOs, state an introduction, describe blood supply, elicit pathoanatomy, enumerate etiology, analyze prognosis, diagnose the case, and outline the treatment. Introduction. Initially described in 1960 by Hemi and Freiberger. It can affect all ages, especially between 30 to 50 years, males more than females, and often bilateral. It is the second most common site of AVN. It is less severe than femoral AVN, or less morbid, because it is non-weight bearing, less constrained joint, and movement could be compensated by the scapulothoracic motion. Anatomy, I will focus on the blood supply only. Blood supply by the ascending branch of the anterior humeral circumflex artery runs parallel to the lateral aspect of the tendon of biceps, long head of biceps. In the biceptal groove, the arcuate artery is the terminal branch, and it gives the majority of blood supply of the humeral head. Something applied. Beware not to injure when plating humerus fracture. Like this case. This is surgical neck fracture fixed by this plate. And this plate may injure the ascending branch of the anterior humeral circumflex artery, led to this amount of avascular necrosis. Back to the point of anatomy also, or the blood supply. The second is posterior humeral circumflex artery. Most current literature supports this as the providing the main blood supply to the humeral head. Also via the rotator cuff muscles through the anastomosis of suprascapular, the thoracoacromial, and the subscapular arteries. The pathoanatomy decrease the blood supply to humeral head, leading to death of cells in bony matrix. And bone is resorbed and remodeled, causing subchondral bone collapse, and may lead to joint incongruity and arthritic changes at the end. About the etiology, I like this classification. is divided into 3 specific etiological factors. The first is atraumatic, too easy, remember this: aseptic, ASEPTIC, pneumonic, A, alcohol, AIDS, steroids, sickle cell disease, systemic lupus, and also rheumatoid arthritis, by the way. Enzyme glucocerebrosidase deficiency or Gaucher's disease, caused by this deficiency of these enzymes, is a genetic disease, or we can say it as a lipid storage disease. Pancreatitis is another cause. Tumor chemotherapy, idiopathic infection, Caisson's disease or acute decompression syndrome, you know this, and finally chronic dialysis. About the post-traumatic and the incidence of AVN, it is 100% in 4 parts fracture dislocation and 50% in displaced 4-part fracture but without dislocation, and 15% in 3-part fracture, and finally 10% in valgus impact fracture. I added this, the 3rd factor, to the classification. Surgical fixation, as I have mentioned before, and it could be after post or after arthroscopic humeral head osteonecrosis. It is reported by Hardy in 2010, and it was the first reported case 8 months after arthroscopic cuff repair due to the use of multiple metallic apparent anchors. Which may have interrupted blood supply of the anteroinferior part of the head. The prognosis depends on the stage of the disease. So we shift to the stages. Creos classification in 1978 classified into 5 stages. Stage 1, with normal X-ray, and it changes only seen on the MRI as this high signal area in the top of the head, just beneath the subchondral bone. Stage 2, sclerosis, wedged and motile with osteopenia. This is stage 2. Stage 3, crescent sign, indicating a subchondral fracture. Like here, this is the diagram, and this is the plain X-ray showing a mild flattening and separation. And this is in the MRI, shows low signal separation lines. Okay. Stage four, flattening and collapse, like here, with possibly fragmentation and even loose body formation. Finally, stage 5 is degenerative changes extend to the glenoid. And this is the final pathway or the end station of a vascular necrosis. There is bipolar osteoarthritis in the head as well as in the glenoid, and almost no joint space. Presentation of the patient. AVN usually starts with insidious onset of the shoulder pain, often without a clear inciting event. As the disease gets worse, it becomes more painful. And in advanced cases, there is loss of motion, crepitus, and weakness. Physical examination, we find limited painful range of motion with crepitus and the weakness of the rotator cuff and the deltoid muscles. Imaging. Radiographs. Recommended views, 5 views, as you know. It is shown best in the neutral rotation anteroposterior. Finding ranging from no finding at onset of the disease process at X-ray. Osteolytic lesion demonstrates resorption of subchondral necrosis. The initial site is superior middle portion of the humeral head. Crescent sign demonstrates subchondral collapse, and finally may progress to consequent arthritic changes. In the MRI, for detection of early or subclinical AVN, preferred imaging modality, 100% sensitivity in detection, and demonstrates edema at the site of the subchondral sclerosis, like here. The treatment in the early stages is non-operative, which in many cases respond poorly. The technique, it is the first line of treatment. Remove the insult like steroid or alcohol, stop smoking, and so on. Medications range from painkiller or non-steroidal anti-inflammatory, bisphosphonates, vasodilators, lipid-lowering agent, and even hyperbaric oxygen. Activity modification and physical therapy. What about injections? Stem cell injection have been successful and superior to microfracture. Patient did not respond to PRP well as in mesenchymal stem cells. Operative. Core decompression to decrease intraosseous pressure to increase the blood flow in the AVN of the hip. The indication is early disease, Creos stage 1 and 2. It works best in the early stages. Core decompression is a safe and effective option, and success rate ranging from 40 to 90%, with percutaneous multiple perforation or one or more reaming of 6 to 8 millimeter advanced in the necrotic area, 1 centimeter apart from the articular cartilage. Something new is arthroscopic core decompression and fibular graft. This technique uses arthroscopic visualization of the lesion, and this has dual benefit. First, debridement to remove the unstable or overhanging articular cartilage and doing microfracture if needed. Second is arthroscopic localization of the infarct definitely will decrease the CR muse and employs an ACL guide to assess decompression as well as fibular strut graft insertion. Adding a new blood supply by using vascularized autograft. Arthroscopic debridement indications: loose bits of bone or cartilage in the joint, frayed edges of joint cartilage, and sometimes the surgeon combines the decompression and arthroscopy as well. Next is partial resurfacing. Hemi cap. The advantage of this technique is replacing only the diseased avascular necrosis, leaving the surrounding articular cartilage as being healthy. So indication is focal necrosis less than 30%, and the disadvantages are no longer in favor or no longer valid, with disastrous results as loosening, fracture, and the migration of the implant. Total head resurfacing or cup arthroplasty indications: stage 3 disease with focal chondral defect more than 30% and sufficient remaining epiphyseal bone stock for fixation. The next is hemiarthroplasty indications: moderate disease in stage 3 and 4 with poor bone stock regardless the degree of head involvement. Regardless the degree of head involvement, like here. Total shoulder arthroplasty indicated in advanced stage Creos 5, total shoulder arthroplasty in bipolar osteoarthritis, and if considerable rotator cuff pathology is present and irreparable, so shift to a reverse total shoulder arthroplasty. So finally, hopefully I could cover the ILO's items. Thank you very much.
شكرا جزيلا استاذنا الفاضل الاستاذ دكتور ماهر بيه العسال. Thank you so much sir.
عفوا يا بيه.
شكرا يا فندم. لو في اي اسئله، لو any questions to Professor ماهر. هو الحاجه الوحيده الكومنت اللي انا شايفه يا فندم في يعني دكتور زميل فاضل كاتب رائع، بس مش اكتر من كده يا فندم.
العفو يا بيه، ده احنا تلامذتك برضه.
العفو يا استاذنا، احنا تلامذه حضرتك يا باشا. ربنا يديم عليك الصحه
حبيبي، ربنا يكرمك.
ربنا يديم عليك الصحه يا فندم.
جزاك الله. المحاضره واضحه.
جزاكم الله عنا كل خير يا استاذنا.
العفو حبيبي، العفو حبيبي.
احنا متشكرين جدا يا فندم. Thank you so much sir. حضرتك احنا I don't see any questions. النكست سبيكر هيبقى طبعا برضه طب اسيوط، طبعا هي يعني قلعه العظماء يا فندم. فاستاذ حاتم بيه جلال زكي هيشرفنا بتوك من التوكس الرائعه اللي اعتدنا على سماعها من حضرته يا فندم.
العفو دكتور محمد بيه، كتر خيرك وشكرا دكتور ماهر بيه استاذنا. يعني احنا طبعا تلامذته. ازاي الصحه بيه؟
هتحفنا بقى
حضرتك دايما حاجه جميله. لا بيه العفو، ازاي تلامذه حضراتكم. استاذ حضرتك نوقف.
استاذنا دكتور ماهر بيه هنستاذن سعادتك نقفل الشيرنج سكرين عشان الدكتور حاتم بيه
حاضر حالا. انا
بعد اذن معاليك يا فندم.
انا بس ده من فوق دلوقتي.
شكرا يا استاذ.
تمام حبيبي.
اتفضل دكتور حاتم باشا.
تمام دكتور محمد بيه الأشهب، بشكر حضرتك طبعا على الانفيتيشن. دايما بنتشرف مع حضرتك ومع استاذنا الدكتور ماهر بيه. هو الحقيقة I wanted to present just a case, it's not a lecture, about a case of chronic anterior shoulder dislocation. Sometimes this is called chronic dislocation, sometimes it's called neglected shoulder dislocation. Both names are available, so I wanted to share with you my experience. So the first part is, when do you say it's chronic or neglected? Is it 1 month, 2 months, 3 months? There's no clear mark in the literature that tells you the definition, or is it acute or chronic? But definitely we all know that shoulder dislocations should be treated as quickly as possible, and they should be reduced, as the more you wait, the more problems you have. We see these chronic neglected cases for many reasons. One of them that they are missed dislocations. Sometimes the patient has other trauma that is unable to do the dislocation, and of course, and sometimes you have to deal with it in a later phase. Actually, I start with a case that we saw about 5 years ago or more, that this patient presented with a chronic dislocation. He had more than 1.5 years of dislocation, and this was the clinical picture of the patient. So he's able to put his arm above his head. He's able to do external rotation about 30, 40 degrees, and elevation, as you can see, up to 150 degrees. We consulted at that time with our Professor Meher and other colleagues in the unit, and it was very variable decision, should we operate or not, because he has a reasonable function. At that time, we also posted it on ViewMedi, and we got 450 replies on ViewMedi. We gave them the options of having a lateral J arthroplasty and non-operative, but actually over 90% of the people voted not to do anything for the patient. So the idea of not doing anything, if he has a reasonable function like this, is actually a good idea. And we also investigated the literature for something like that. So this patient we did not operate on. But I was confronted earlier this year with a patient who's 21-year-old with 5 months bilateral chronic anterior dislocation. And this was his CT. So I want you to look at the CT carefully. Both actually right and left are similar. So we have a chronic anterior dislocation. We have a new pseudoglenoid that's available. Let me put the marker on. We have the new pseudoglenoid, and we have a malunited greater tuberosity. Now, if you look at the glenoid itself, there's not a lot of extensive bone loss for the glenoid, but there is the chronic dislocation itself. So that was the dilemma again. And I want to show you the clinical picture. This was his clinical picture pre-op. So again, elevation 130, 140, abduction maybe 80 degrees, and external rotation here is actually very limited. He only had 0 to 10 degrees of external rotation. So this was his problem. So again, knowing the previous knowledge, my question was to him, are you satisfied with this function, or do you want to have the operation? So we know that these cases are extremely difficult and the outcome is not always guaranteed. So one is hesitant to rush into this, and you have to make sure that the patient is unsatisfied. And the patient actually chose to have the operation. And I was hesitant because it's been 5 months chronic dislocation. So actually I decided to proceed with the left side. And I told them I want to see what the outcome is before we decide to do the other side, and you have to make up this decision. So again, the big question is, should we operate or not? That's question number one. So looking again at the literature, many people have shown that these chronic dislocations have a reasonable outcome. So they have this good elevation, external rotation, not so bad. Internal rotation is quite limited, and this is one of the factors the patients mentioned. They have limited internal rotation. So other papers also, again, have shown that even after many years of chronic anterior dislocation or neglected anterior dislocation, they still have a reasonable function. So always consider that. So when the patient wanted to have the surgery, and so we started analyzing all the problem. We started with the left side. So we have the chronic dislocation. Definitely that led us to soft tissue contracture. And soft tissue contracture is actually both posterior soft tissues are contracted because it's dislocated. So it's actually closer, it's slightly in rotation. He does not have any internal rotation. So your posterior soft tissue structures are contracted. Secondly, he's not having any external rotation. So your anterior subscap is contracted, and that makes it very difficult to reduce and while you're having the surgery. So that's another problem that you will face after the operation, is trying to stretch his anterior soft tissue structures. Number 3 is, do you have any anterior bone loss or not? We know that we have the pseudoglenoid in which the humeral head is articulating with, but that doesn't really cause much of a problem. It elevates the subscap slightly, but it's not a major problem to deal with it, but rather that do we have a glenoid bone loss or not? Then we have the malunited greater tuberosity, and that was a new element for me, that the tuberosity actually had broken. So this previously was a fracture dislocation of the humeral head, and then the greater tuberosity malunited. So that added more to the problem, and that was the bilateral. So he had bilateral fracture dislocations of the shoulder. And then lastly, you always worry about what's the situation of the cartilage after so many months of dislocation, and that the humeral head is moving in this pseudoglenoid. So always, all these things we thought about. If you look at the axial CT, you can clearly say the pseudoglenoid, and that the humeral head is part of it is articulating with this part. So the plan was to do a deltopectoral approach. We initially thought that should we do a lateral splitting, but I know that it's very difficult to reduce. So we did a deltopectoral approach. We decided obviously that the greater tuberosity must be reduced. The cuff, the supra and infraspinatus is attached to that. Open reduction, that is the most difficult part, is actually reducing the joint after so many months. And from previous cases that I've done, I've realized that sometimes you're unable to do just the reduction by yourself. You have to release part of the subscap. Either you go through the interval, because part of the plan is to do a lateral J, or you actually completely release the upper part of the subscap. Then you do your reduction. Then you know that your lateral J will be leaning on your lower part of subscap, and then you repair back your upper subscap. So don't be hesitant in these chronic late cases to remove the cuff, get back everything into place, and repair the cuff back. And this is one of the things I've learned from these complex cases. Now, lateral J has two benefits. One, if you have an extensive bone loss of the glenoid, which you may or may not have, but even if you don't have bone loss, all these chronic cases, I plan to do a lateral J, because you need something to push the humeral head backwards. And as soon as you reduce the joint, it reduces, but it automatically because of the shrinkage of the tissues, be it posterior and inferior and anterior, it always jumps back into place with minimal movement. So you need something to be continuously pushing it back into place, and that is the function of the lateral J. You're pushing on the subscap, the lower subscap, to keep it back into place. And then we need to fix the greater tuberosity back with a plate. Now, for the posterior soft tissue contracture, what we do is before you reduce, you try to release all the tissues behind the glenoid with an osteotome. So we come back with an osteotome, release the infraspinatus. It's usually adhered to the posterior glenoid. You try to release that all the way, and that gives you some internal rotation. For the subscap, which is also very shortened, that is more difficult. I mainly depend on the physiotherapy post-operative to work on that. And usually they do regain some range of motion. It takes time. As soon as you finish the operation, they only have 5-10 degrees maximum. But as soon as they work with the physio, gradually they work on the subscap. We try to do a little bit of anterior release of the subscap just under the muscle belly to just get any adherence off. But again, it doesn't give you that much intra-op, and I know that they will have to work on it post-operative. So this is that was the plan. I mean, obviously this plan, we had all the options on the table. We don't always do all these steps, but we had this all prepared. So this is after 1 month follow-up. So as you see, we're able to reduce the joint into place. We did the lateral J with 2 screws. We returned the greater tuberosity into place. We had to refresh both surfaces of the humeral head and the tuberosity from all the fibrous tissue, put the tuberosity back. And that involved repairing the cuff because the tuberosity was in a different place. Once you release it, we released the cuff. Also the subscap, we had to release upper parts. So we had to do a cuff repair at the end, make sure that the anterior and superior, anterosuperior cuff are in place. This is at 5 months follow-up after the operation. So he had the left one done, he had the right one not done. And that was the interesting part. What is the outcome? And this is the actual pictures of the patient at 5 months. If you look at both, so if you look at the left shoulder from the back, it's nicely contoured. The right shoulder, you can see the wasting of the supra and infraspinatus. Abduction is not much similar. Even flexion, the right side, which is the non-operated, had a better outcome than the left side. So common sense is I expected the patient will say, I'm happy, I don't want to have it done. There's not much difference. This was my impression, but actually the patient came for the second surgery of the other side. And the question is, I told him, why do you want the operation? There's not much difference. But if you look at, he was also upset about the contour of the shoulder, but the major difference was the internal rotation. So as you can see, he can use his arm, get back internal rotation. Obviously, this is important for personal hygiene to have this level of internal rotation. The other side, the right side, the unoperated side, it was very limited with internal rotation. So this was my surprise because now we were over 9 months delayed for right chronic dislocation. And just to give you a heads up, I actually did operate on him about 2 weeks ago on the other side. We did the same procedure. We did the osteotomy of the greater tuberosity, the releases, the upper subscap, and put back everything in place. His cartilage, however, I have to say, was not as healthy as the left side. So I did notice softening of the cartilage of the glenoid operating on the right side. So I hope this will proceed well also and have a good outcome. But we did the same procedure. We're able to reduce it. He came back 2 weeks follow-up. Everything is in place for now. And I hope he also has a good outcome similar to the left side. So in summary, when you have a neglected anterior shoulder dislocation, always ask yourself, now, should we operate or not? Does this patient have a reasonable outcome and function? If he has a good function, he's satisfied. I mean, we know he's not going to get 100%. You should always communicate that with the patient. And if he's unsatisfied, he needs the hand to do more, to reach more for personal hygiene or for his job, then think of the problems you will face from anterior and posterior soft tissue contractures, from the bone loss, and that you will need the lateral J even without bone loss. Always do a lateral J for that, and steps of the reduction, and that you might release the upper subscap to be able to get into the joint, get your fukuda, and reduce the joint back into place. Thank you very much for your attention.
Thank you so much, Professor Hatem Jalal Zaki, for this very interesting case presentation. Thank you so much, sir.
Thank you, Prof.
If we have any questions to Professor Hatem, دكتور عبد الرحمن الجنايني معانا. Professor عبد الرحمن.
معاك. ازي حضرتك؟
ازي حضرتك يا فندم؟ منور.
اهلا وسهلا. نور حضرتك. صح.
الله يخليك يا فندم.
انا كنت عايز اسال سؤال بس للدكتور حاتم.
دكتور ماهر بيه، اتفضل يا استاذنا.
The right side if not went well as in your mind, what is in your mind also to do in the future?
يعني هو the only concern is the cartilage status. يعني that's the only concern for the right side. إن هي دخلنا في 9 months, so the cartilage was a bit soft. So I hope, I mean, obviously, if the chondrolysis happens, then it will go into osteoarthritis. Then there is no option but to do something like a resurfacing arthroplasty or a total shoulder arthroplasty. But I hope he does not reach that stage. So obviously in the physiotherapy, my recommendation to him and our physiotherapy team was to take it slow, not try to attain rapid range of motion more than he had pre-op, so that we're not pressuring the cartilage and just giving it time to develop back.
Well, thank you very much.
هو في سؤال لسعادتك دكتور حاتم بيه من زميل فاضل، يعني بيقول هل screws are the screws enough for fixation؟
السكروز فور لاتر جي ولا قصده سكروز فور ذا جريتر؟
غالبا فور لاتر جي. حضرتك الجريتر تشيبراستي حضرتك فيكسنج ات with plate and screws.
هو اللاتر جي we only have screws، ما عندناش option تاني but to fix it with 2 screws and that's usually enough. It's usually strong, good enough, and it maintains the shoulder in place.
Yes, sir. هو كاتب for the greater tuberosity. ما هو حضرتك الجريتر tuberosity fixing with a plate.
A greater tuberosity يعني we thought it's a big piece of bone. Obviously it's an option in انت you fix the greater tuberosity with screws, but with chronic cases and the bone sometimes is osteoporotic, there's a risk that when you fix the tuberosity it breaks up, and we've seen that before happen. So that it ends up that you only have to at that time put a screw in the tuberosity and do a post with suture bands to come on the distal post screw. If you only depend on screws in the tuberosity with the soft bone, sometimes it breaks up. So I prefer the plate to act as a buttress and to have some screws inside, and I also take the cuff with some sutures into the plate to act as a post.
Yes, thank you so much, sir. We have no other questions, so we will move to the next speaker, Professor Abdurrahman Al-Ganaini, Mansoura University. Professor Abdurrahman, تفضل يا فندم.
بسم الله الرحمن الرحيم. كل سنه وانتم طيبين. طبعا انا سعيد جدا بوجود النهارده دكتور محمد، وبشكرك على تنظيمك وجهدك، ربنا يوفقك ان شاء الله.
شرف لنا وجود حضرتك.
تقدم وابداع ان شاء الله. تحيه طبعا استاذ الدكتور ماهر بيه العسال، طبعا سعيد جدا شفته النهارده، والاخ الزميل الفاضل الدكتور حاتم بيه. فطبعا كان شرف كبير ان احنا موجودين مع عمالقه طب اسيوط، وان شاء الله نشارك برضه بعض الحالات في الكرونيك نيجلكتد ديسلوكيشن مع الدكتور حاتم بيه ان شاء الله. ثانيه واحده كده عشان نعمل ان شاء الله السكرين. تمام كده يا وزارة محمد؟
لا لسه ما ظهرتش يا فندم.
انا عملت شير سكرين بتهيألي.
هو حضرتك هو ظاهر الديسكتوب بالحاجات اللي عليه، بس لسه البرزنتيشن نفسها ما فتحتش يا فندم.
يعني افتح مش باينه دلوقتي؟
سعادتك افتح البرزنتيشن الاول وبعدين اعمل شيرنج سكرين يا فندم.
تمام، انا فتحت البرزنتيشن فعلا اهو. المفروض ان هي جت كده. انا عامل شير سكرين اوريدي فعلا. مش واضحه؟
هو حضرتك ظاهر الديفرنت برزنتيشنز، بس لسه البرزنتيشن نفسها ما فتحتش يا استاذ.
لسه ما فتحتش.
هو حضرتك عليها ظاهر الكرونيك نيجلكتد انتير شولدر ديسلوكيشن.
تمام. طب ما انا اكمل يعني، ممكن بقى اقدر اعمل هو سكرين او يعني ماشي معايا الوقت كويس كده؟ باينه؟
لا لسه ما فتحتش يا فندم.
غريبة، نجربها قبل ثانية بثانية واحدة تاني، ارجع تاني بقى في.
سعادتك ارجع وافتحها وبعدين اعمل شير سكرين يا فندم.
طيب انا عملت ستوب شيرنج تاني اهو.
تمام يا فندم، افتحها سعادتك الاول.
تمام، ثانية واحدة. انا كده اهو. تمام. اعمل شير سكرين. تمام كده حضرتك كده ظهرت؟
كده ظهرت يا فندم، اتفضل سعادتك.
تمام معلش انا اسف على
لا العفو يا فندم، العفو يا فندم، العفو يا فندم. تسلم ايدك يا فندم.
الله يكرمك. بسم الله الرحمن الرحيم. برضو ان شاء الله نشارك بعض الحالات ما جاء قدرا ما نعرفش والله ان الدكتور حاتم هيتكلم برضو على الشولدر ديسلوكيشن نيجلكتد. كان عندنا برضو بعض الحالات في المنصوره فهقدمها برضو ان شاء الله، واتمنى ان هي ربنا يسهل وتكون برضو مفيده يعني. هو طبعا في انترودكشن موجوده الحالات زي ما الدكتور حاتم بيتفضل ان الكرونيك شولدر ديسلوكيشن حاجه ديبيتابل، ويا ترى نعمل ولا ما نعملش. احنا جات لنا حالات فعلا اوريدي ما عملناش حاجه، وفي حالات كانت بتشتكي ان هي تعبانه والرينج اوف موشن كان قليل. دكتور حاتم بيه كانت الحاله معاه يعني لكن الحاله كانت فيها رينج اوف موشن كويس، لكن بعض الحالات اللي انا هشاركها مع حضراتكم دلوقتي كان الرينج اوف موشن مش كويس. انا بس هقول يعني مقدمه صغيره جدا عن التشالنج لما نيجي نعمل حالات اللي هي الكرونيك نيجريتيف ديسلوكيشن. اول حاجه في الريدكشن لازم مهم جدا to have a good radiography to demonstrate the direction of dislocation. Sometimes we have posterior dislocation and the X-rays will be not evident, so you have to do CT. And you have to confine the chronicity of the symptoms and the exact range of motion. You have to document all of this. After we do reduction of these cases, we have to search about stabilization. And so I agree, most of the cases needs to stabilize by letter J or something bone block. The articular defects, very important to have to know the articular defect on the side of the glenoid and on the humeral head side. Sometimes you have to do graft or sometimes like something like this. And also rehabilitation is very important. The patient must understand the rehabilitation program is very important to have a good function after this major surgery. And pain relief is sometimes minimal. Some patients have pain, and the patient after articular cartilage defect repair, we have pain relief for these patients. We do the surgery on bed chair position and deal to pectoral approach as Dr. Hatim said. This is a case I will pass this case presentation. The case number one, he was an old male, 48 years. He had a limitation of movement of the right shoulder after minor trauma. He had no significant trauma. And the patient searched medical treatment after 2 weeks and presented to us 3 months after the trauma. This is the patient. You see this right shoulder was dislocated and the left is good. And we can see the waist. You can see the wasting of the infraspinatus behind the shoulder. And this is the X-rays of the patient. This was the first case we did since about 7 years. This is the CT. We can see the head is locked to the glenoid. And we have a big Hill-Sachs lesion, as you see. We opened deltopectoral. And after we have removed the subscapularis, the patient, we have this picture. We have the head in front of us, and we have to do very good release of the head and soft tissue. This is the subscapularis with flicker of bone. And this is the Hill-Sachs lesion. And we did allograft for this Hill-Sachs lesion to achieve good reduction. And after with this is the conjoint tendon. We fix we have to do letter G and fixing the coracoid process by screw. This is the patient after follow-up. He have a good range of motion. Unfortunately, he had bad range of motion before surgery. And this is the X-ray after the 9 months after the surgery. Another case was an epileptic patient. He has sustained moderate trauma and presented to us 6 months after the trauma by marked limitation of movement. This is the X-ray of the patient. You can see this. You may be deceived, but after the CT is, you can see the head coming anteriorly, and the patient also had a very big Hill-Sachs lesion. CT, you can see the empty glenoid, and the head is locked. This patient had very limited range of motion. He can't raise no abduction, no flexion. We proceed to surgery, and this is the patient after we have to, after we remove the soft tissue, and this is subscapularis with a stay suture, and this is the head in front, and this is the Hill-Sachs lesion in front of you. Again, we do release of the most of soft tissue of the capsule, and we do graft for this Hill-Sachs lesion to attain good reduction. And after that, we do a good release. We try to put the head in the glenoid, and we succeed to put the head back into the glenoid. It is a la carte. You have to be very cautious and to do release step by step, and so, it takes time. Don't be in a hurry to do reduction. Sometimes the tissue, as the cartilage is very soft, and you may injure the soft tissue. After that, we do also lethargy and repair of the subscapularis. And this is X-ray post-operative, and we have to fix it by the subscapularis with anchor, and this is the lethargy procedure. This is post-operative X-ray, but we have early post-operative photo, but the patient didn't come again. This is after 1 month, but he had some range of motion. The case number 3 is a female patient who is 21 years old. She sustained a motor car accident and diagnosed as brachial plexus injury, and presented to our clinic after 4 months with painful right shoulder and limitation of motion. This is the X-ray. As you see, also the head, a big Hill-Sachs, and the head is locked in anterior position. Photos were not good. Operative details after deltoductal approach, the biceps tendon. In most of the case, we have to do bicipital tenodesis. And after we remove the subscapularis, the head coming in front, and then we do reduction and we do lethargy. Sometimes when we do bone block, you can overcome the defect in the head, and not all the times you have to do graft for the humeral head. And the patient, this is the final follow-up. But we didn't do surgery for the greater tuberosity. And this is the patient had some range of motion, much better than previous. Sometimes we have posterior dislocation. Posterior dislocation mostly is neglected, and we have to do CT. X-ray, how can you suspect posterior dislocation? In the AP view, you will see the head is fixed in internal rotation, and mostly it is high up in the glenoid, and we see the trough sign. This fracture line, we see it into the head of the humerus. This case was 22 years, motor car accident. He had injury, multiple fracture ribs, and shoulder diagnosis was after 6 months. And this is the CT. You can see the glenoid is empty and the head is back posterior to the glenoid. Very important to do CT if you suspect the posterior dislocation. Again, this is a glenoid, and this is the head impacted on the posterior lip of the glenoid. Another CT. Here we do McLaughlin procedure. It is very simple, and with the anterior transposition of the lesser tuberosity. This is the patient intraoperative. This is the trough sign, as you see it. And this is the flicker of bone from the insertion of the subscapularis. And then we do release. And we then do anterior position of the subscapular. This is the post-operative. The head is inside the glenoid. And this another X-rays, the patient doing well. Another case was female, 42 years, falling from mild height and misdiagnosis 6 months, also posterior dislocation. In the surgery, you have to, most of these cases, posterior dislocation, the patient, you can't do any range of external rotations. The external rotation is very limited. So you can do internal rotation, but no external rotation. This is a photo. She had also big Hill-Sachs lesion. And here we do autograft from the iliac bone, fixed by 2 screws. And after that, we refix the subscapularis with its stay suture, and the patient do well. This case is different, was 63 years, had fracture dislocation. As you see, the head is a fracture. We decide to do internal fixation, as we have no ability to do arthroplasty. This is the X-rays, and this is the CT view. This is the early intraoperative X-rays. Also, we did coracoid position, coracoid bone block to add for stability of these patients. Most of these cases need bone block to add stability and to push the head inside the glenoid. This is X-rays, and the patient had some range of motion. The last case was female, 44 years, was epileptic, and misdiagnosed also for 6 months. And you can see the very big Hill-Sachs lesion. And also we did a graft was fixed by 2 screws, and then we re-putting the head inside it, and you can see the range of motion is better because you overcome the part which is defected inside the head of the humerus, and so the head will be stabilized again. And also we did refixing the subscapularis in anterior position. To summarize, this cases needs to understand the case and to put a good plan and to do your decision of surgery after you finalize studying of the X-ray. The articular culture state very important if you will address the glenoid side defect, or you will address also the head of the humerus. And when you do surgery, be very meticulous. Soft tissue, take your time to dissect the soft tissue and to do good release. Sometimes the long head of biceps is a tethering problem. You have to do tenodesis. Subscapularis, you have to remove the subscapularis to make your approach is better. And after that, do reduction easily. Don't do forced reduction for not healing the articular cartilage. And after that, you have to do bone block with lethargy or something like this. And don't expect much big results. The result
دكتور عبد الرحمن بيه، حضرتك معانا؟
مع حضرتك سامعني؟
بس هو السكرين فصل عن سعادتك.
والله من امتى؟ من زمان
لا
ولا ايه؟
حالا يا فندم، حالا.
تمام
حالا يا فندم، لسه فاصل حالا على اخر صوره سعادتك كنت فيها.
طيب
كيس نمبر 7. كيس نمبر 7.
ماشي. اقولها تاني؟
هي بس حضرتك على اخر صوره سعادتك كنت عليها في كيس نمبر 7.
تمام. انا بس هقول لحضرتك، انا كنت بقول يعني السمرايز
بالظبط يا فندم.
سمرايز بالظبط. summarize this cases. I think we have to be meticulous to put a good plan for management of these cases because we have very many problems. The bone defect you have to address. Either you will address the bone defect on the glenoid side or on the humeral head side or both. Sometimes you need to address both sides. Okay? معايا دكتور محمد؟
يا فندم.
تمام. Number 2, when you decide to do surgery, you have to be a la carte approach. So you have to do release, good release. Don't be pushing to do forced reduction of the head because you may injure or may fracture the humerus. Sometimes you have fracture of the humerus by forced reduction. The biceps tendon, you have to know. Sometimes it is a tethering factor. You can do bicipital tenodesis. And letter J is very important to add stability after you reduce the head inside its position. Rehabilitation is very important, and you have to put the patient that to know the patient know the patient that the range of motion will be as the same before the injury, because sometimes the expectation of the patient is more than you do. That's all, and it is very rare cases and very difficult cases needs to do this plan for. Thank you.
Thank you so much, Professor Abdurrahman Ganani, Mansoura University. Thank you so much, sir. دكتور عبد الرحمن بيه، احنا we have a question من دكتور مصطفى الراوي. I have one case of chronic locked shoulder anterior dislocation, 20 years old, 2 years locked shoulder with arthritis. What do you recommend?
If we have a severe arthritis and the case of the articular cartilage was bad, I think you have to think before surgery, because the end stage will be arthritis. So I think don't do this surgery. If you have evident arthritis or high grade arthritis, and so what's the benefit? The patient will end by arthroplasty.
Yes, sir. If we have any other questions to Professor Abdurrahman?
The appearance of AVN in your series.
Okay, one case. Okay, so one case had an AVN is a patient who had very big Hill-Sachs lesion and had very big distance before surgery. But even in these cases, the pain was not severe, and the patient don't seek for another management.
بحييك على السيريز الجميله دي يا دكتور عبد الرحمن.
الله يخليك دكتور مهدي. الله يخليك.
الحمد لله.
We have another question من دكتور أحمد زهدي. Can we do soft tissue release after open or arthroscopic after neglected dislocation to increase the range of motion after healing of the primary procedure?
The contraction of soft tissue is a very big issue in these cases, and so you will not able to do a reduction of the head before you do a massive release of soft tissue. Sometimes you release the capsule from most of the head, and attach on the humerus of the glenoid. And the subscapularis, you have to, as I said, you have to release the subscapularis. And so you have to do as much as you can soft tissue release, because most of them coming present to us after 6 months, and nothing for even after you did this release, you will have some limitation of range of motion.
Thank you so much, sir. شكرا جزيلا استاذنا الفاضل استاذ دكتور عبد الرحمن بيه جنايني. يعني دايما حضرتك سبورت لنا كده في الكورس معانا يا فندم.
ربنا يخليك يا دكتور محمد بيه، ما تحرمش منك ابدا. ربنا يخليك. شاكرين جدا
معانا يا فندم.
شاكرين يا فندم. شكرا جزيلا.
Very good job.
شكرا دكتور ماهر بيه، شكرا يا فندم. Our next speaker, one of the top eminent stars of shoulder surgery في مصر, بروفيسور محمد صبحي عن شمس يونيفرسيتي. بروفيسور محمد اتفضل يا فندم.
السلام عليكم.
عليكم السلام ورحمة الله
Good evening, everyone. I hope you are all doing fine. Today I will discuss with you one of the interesting cases and the way it was treated. I think by now you are seeing my screen now.
Yes, yes.
Right, Dr. Muhammad?
Yes.
Okay. So I will discuss with you one of the most difficult situations in shoulder surgery, which is the rotator cuff, massive rotator cuff, especially if it is irreparable. What is the massive rotator cuff? The definitions maybe are not well. There is no reached consensus about the massive rotator cuff. Some say it's more than 5 centimeters. Some say more than 2 tendons. Some say that it is a rotator cable discontinuity, or that extend to the subscapularis with long head of biceps. All these are descriptions to the massive rotator cuff. The problem with the massive rotator cuff, when it reaches to a point, a break point of the unbalanced force couple around the shoulder, will cause a detrimental effect and osteoarthritis of the shoulder, or what's called the Milwaukee shoulder, which combines the weakness, pain, and stiffness, all of them, with head migration up and friction with the acromion, leading to detrimental effect of the shoulder joint. But we don't need to reach this detrimental final reach. So let me discuss with you this case of a nice lady, 57-year-old female, with actually she has a depression with and on antidepressants. She fell on her outstretched hand a month ago, and now she has pain, weakness, pain, and stiffness, as you see, with pseudo paralysis, as you all see now. Is it clear, Dr. Muhammad?
Yes, sir. Clear, sir.
Okay.
Clear.
So actually with the clinical examination, she has a positive drop arm, positive lift-off test, and positive horn blower. But actually the lift-off test was weak, not positive all the way. It was weak than the other shoulder. And she had anterior pain radiologically. She has a little bit of migration, and she has still she doesn't have an arthropathy on the plain X-ray. But on the MRI, the tear size was more than 5 centimeters. The long head of biceps has a minimal subluxation on the MRI, especially in the higher cuts. But the superior, the supraspinatus, I mean, has a retraction till the glenoid, with atrophy and infiltration more than 50%, as you see here. This is the infiltration that we this is the retraction that we have on the MRI. But actually, this was an old MRI. But the situation in operative was than what you see now, because actually the edge of the supraspinatus that you see here with the 2 to 3 centimeter retraction, actually it was reaching beyond the superior glenoid. As we know, the recent MRI before the operation with the large and retracted supraspinatus with the fatty infiltration and atrophy of the muscle belly. So when you face a situation like this and this kind of lady, I want to raise the issue that she has depression and she is on antidepressant. So you will all the treatment option must come into your mind. Either the repair, even the partial repair, the marginal conversion, the medialization of the cuff, if you can't reach a good tension or good excursion of the tendon till the greater tuberosity. Also, some researchers came out with that the subacromial decompression, mere subacromial decompression is more than enough in such an acromioplasty is much enough, and the patients will do better with these simple solutions only. Also, the biceps tenotomy, and we all know the school of biceps killers, and also the tendon transfer, either the pec to subscapularis or latissimus dorsi to supra or infraspinatus. And finally, if the patient has the upward migration and the destruction of the shoulder, the reverse shoulder arthroplasty, the in-space balloon, dermal or fasciolata superior capsular reconstruction, SCR. But actually, the biceps hoodie actually is a solution. Actually, it was invented many years ago with our mentor, Dr. Izzat Kamil. May his soul rest in peace now. But he was insisting to use the biceps and make use of it, and used to name this the repair of the supraspinatus. These are the simple solutions. The repair, if the massive repairable, if it is repairable tears, the partial repairs with the solution of the medialization beyond the greater tuberosity 1 centimeter or 8 millimeters, taking down the edge of the head articular cartilage for few millimeters or even up to 8 millimeters to medialize and release the tension on the repaired tendon. Also, the margin convergence with the repair to decrease the size of the U-shaped and V-shaped injuries or tears. Also, the partial repair with the repair of the infraspinatus to subscapularis. This is actually a good solution to make a partial repair, and many of the patients can do better with this kind of surgeries. This is the simple debridement arthroplasty. The muscle transfer, maybe it is good for the but the function with the muscle transfer, the least or the last evidence about the muscle transfer, maybe it is the patients will not do good as regard the function. And actually, the reverse arthroplasty is a very good solution, but it is costly a little bit. Also, the in-space balloon to depress the head and make the shoulder move again to reverse the imbalance of the force couple around the shoulder and make the shoulder forces come back to normal again with the head depression. and the least solution, maybe it has a very good repeat construction now, either with the transdermal allograft or the synthetic graft or the autograft of the fascia lata, but the technique is technically demanding, and you must and time consuming, and it is they need put 6 to 7 anchors into the shoulder. This will cause some cost-benefit issues, and this is another solution that I was talking about now. Let's see the situation. This is the superior labrum, and this is the superior labrum. This is the acromion, and actually the tendon is vanishing here. It has a very large retraction. This is the long head of biceps, and this is the greater tuberosity. Actually, this is a massive tear. The supra and infraspinatus, upper half of infraspinatus, with part of the infraspinatus was torn. Eventually, the patient has a good tissue, subscapularis tendon. I tried to release a bit the supraspinatus and see the excursion of the tendon and see if it can come back to the greater tuberosity or not. Here I'm trying to do some releases above and below the supraspinatus tendon to release some fibrous tissue. The radio frequency here. But actually the situation was a bit difficult, and supraspinatus was very atrophic, as you see, very atrophic, and it doesn't come out to the greater tuberosity by any means. This is the greater tuberosity trying to clear the soft tissue still attached to the greater tuberosity. This is the head, and all the head at the very big tear. Here I'm trying to release the long head of biceps into the groove. I didn't cut the biceps. I didn't kill the biceps, and I prefer to release the biceps and make it free, but still it is attached to the superior labrum and the muscle belly lower down. I tried to make some sort of margin convergence to decrease the size of the gap. I tried to repair some of the tissues of the infraspinatus to the supraspinatus as a sort of margin convergence between these two tendons to decrease the size of the gap. Maybe it helped, but to a very minimal limit, and still there is a big gap, and the head is totally exposed to the acromion, as you see here. And this is when when I decided to do the option of superior capsular reconstruction with the biceps hoodie, as you see here, I shifted rerouted the biceps to attach it to the greater tuberosity as a way of reconstruction to the superior capsule to reverse the head elevation to make the force couple around the shoulder come back to normal again. This is a 4.5 corkscrew anchor, and I sutured the supraspinatus. I rerouted the long head of biceps to the greater tuberosity. And actually, I left the distal part of the tendon. I didn't cut the tendon. I just left the tendon attached distally. And this actually didn't make any difference with the pain. It didn't cause any pain. This is the here I'm trying to do on top of the long head of biceps partial repair to attach the subscapularis. This is the upper border. This is the upper border here, upper border of subscapularis, and this is the upper border of the left infraspinatus. Actually, the upper border of the subscapularis come freely to the level of the long head of biceps. But the infraspinatus was a little bit tight. So I made the partial repair of the infraspinatus or upper border of infraspinatus to the long head of biceps, as you will see now. I put another anchor. Again, 4.5 corkscrew anchor, double loaded anchor. And I passed the suture into the upper border of the left infraspinatus. A suture, one suture passed into the infraspinatus directly, and the other one used to approach or make the infraspinatus to be sutured to the long head of biceps as a kind of partial repair. Still, there is some gap, but when I sutured the infraspinatus to the long head of biceps, the gap decreased finally. This is more or less a shoelace configuration. It's a complex configuration of tying two tendons together, but it helped too much to close the gap and to cover the head and do depression of the head to be in front of the glenoid cavity again. And I did actually the same for the subscapularis. This is the upper border of the subscapularis, and I sutured it down to the long head of biceps. And actually, this is the best I could do for this patient with what I have in the operation. And I thought that she will need actually at a certain point later on a reverse shoulder. This is the head. This is a completely different situation than the situation we started with. We all maybe remember the total uncoverage of the head. Now the head is covered. This is the previous view. The head was totally uncovered. And this is the situation now. But still, I had doubt with this partial kind of partial repair with superior capsular reconstruction with the biceps, long end of biceps. I had doubt that the patient will do good, but this is 2 months post-operative. This is the post-operative of the patient. There's no much pain. The patient can do the elevation maybe to 160 or something. And she has also internal good or fair internal rotation as compared to the previous situation. Maybe even with the superior capsular reconstruction or the reverse shoulder arthroplasty, we'll have similar or maybe less results than this. So my take-home message: don't always kill the long head of biceps. It may help for superior capsular reconstruction and help the head depression. And when combined with the deltoid rehabilitation, it will compensate with for the unbalanced force couple to decrease the pain and to increase the incidence of the osteoarthritis, the inevitable osteoarthritis with the situation like this. It has a better function, although it is technically demanding, but actually it has a lower cost than the conventional, superior capsular reconstruction with transdermal or the fascia lata autograft, or even the reverse shoulder arthroplasty. Thank you. I hope the case was nice and it raised certain indication for the use of the long head of biceps.
Thank you so much, my dear Professor Muhammad Sobhi and Shams University.
Muhammad.
Very interesting case presentation. Thank you so much, sir. If we have any questions to Professor Muhammad. يا فندم. سعادتك سامعني يا فندم؟
دكتور محمد؟
انا بس مش سامع قوي. ثانية واحدة يا دكتور محمد. معلش انا كنت قافل الصوت عشان الاخر فيديو كان ليه صوت.
انا بشكر حضرتك فندم، شكرا جزيلا. Thank you so much sir for this very interesting case presentation. If we have any questions to Professor محمد صبحي.
دكتور محمد معاك عمرو قنديل.
اتفضل دكتور عمرو. Please sir.
First, my deep appreciation to Dr. Muhammad Sobhi for this nice presentation and elegant technique. I have two questions. The first one, while doing or using the long head of the biceps for superior capsular reconstruction, what is the site of tenodesis of the biceps? And the bicipital groove just lateral to the articular cartilage, or does he prefer to shift it a little bit more posterior to be central or in line with the scapula? This is the first question. Second question, in his own clinical practice, what is the cutting edge between arthroscopic or all arthroscopic and mini open repair of massive retracted rotator cuff tear? When does he prefer to do mini open, and when does he prefer to do arthroscopic of massive retracted rotator cuff tear? Much thanks, Dr. Muhammad.
Thank you sir. Professor Muhammad.
شكرا دكتور عمرو, the eminent and clever my clever surgeon. Very nice questions. The first question is the site of the biceps tenodesis. زي ما قلت لك يا عمرو, I prefer to make it halfway between the gap. يعني بالظبط anteroposterior halfway. The gap between the sub and infraspinatus, and actually I suture it at the edge of the, or just lateral to the edge of the cartilage. الحقيقة عمرو يعني sometimes I do superior capsular reconstruction even with the repair لو in some large tears, when the quality of the tendon is not that good, or I have some doubt about the quality of the tendon, some time I do long head of biceps, the superior capsular reconstruction, and on top I do the repair of the supraspinatus. And sometimes I use an anchor, special anchor for the biceps tenodesis only. Medially, then I do the double row repair of the supraspinatus, or double row or single row, whatever the situation is. Here I use the long head of biceps as a graft for the superior capsular reconstruction, and as well to help in the partial repair. Maybe this is not depicted or was
Professor Muhammad. I think Professor Muhammad has a problem with the connection. Finally, I would like to thank Professor Muhammad Sobhi from Ain Shams University for his very interesting case presentation. Now, I would like to welcome and thank from the bottom of my heart Professor Moeen Khan from McMaster University, Canada, for joining us today in our Shoulder Specialty Day webinar. Professor Moeen, you are very welcome, sir. Professor Muhammad, you are with us.
معلش حصل بس حاجه في
اتفضل يا فندم.
بالنسبه للسؤال الثاني بتاع دكتور عمرو قنديل, فبص يا دكتور عمرو, the second question is what is the cutting edge to do mini open? The cutting edge to do mini open is the surgeon preference. Do whatever you are doing well. لو أنا بعمل, if I'm doing the mini open better than the arthroscopic, I'll go for the mini open. If I'm doing the arthroscopic better. I mean, do after a while, the results are the same.
Thank you so much, Professor Mohammed Sobhi from Ain Shams University. Thank you so much for your very interesting case presentation, sir. Now we move to the next speaker, Professor Main from Arthroscopic University. Thank you so much, sir. Professor Main, you are very welcome. Thank you so much for joining us today in our Shoulder Specialty Day webinar. Thank you so much for being with us, sir.
My pleasure. Thank you very much for the invitation.
Thank you so much, sir.
All right. So over these next 30 minutes, I'll be talking a little bit about anterior shoulder instability and sort of what's new in 2021. And I'll just end my talk as well looking at how I personally do a Bankart repair with remplissage and just some tips and tricks for if you're performing this procedure. So we'll get started. So these are my disclosures, none of them are relevant to this talk. So why is this an important topic? Well, we all know that the shoulder is the most commonly dislocated joint in the body. Actually, in the United States, there are over 70,000 shoulder dislocations that occur every year, and these primarily affect young male patients. And anterior shoulder dislocations are the most common form of shoulder instability, and recurrence rates are actually very high. You'll read different numbers, but most of the studies will suggest a subsequent instability rate at around 14 to 15%. And with improved recognition of bony defects and their contributions to recurrent instability, this really has led to an improvement recently in our treatment algorithms and how we manage these patients. So sometimes things are very clear when we're managing shoulder instability. The image on the left, I think most surgeons would proceed with a capsule ligamentous repair or Bankart repair. And the image on the right, I think most surgeons would proceed with some sort of bony augmentation. But I want to illustrate how things can get a little bit more challenging or a little bit more thoughtful with this case. So a 26-year-old patient who had an initial instability event about a year ago. They're an MMA fighter. They subsequently had 5 dislocations, 4 in the last 2 months, and they're otherwise healthy. And if you look at their imaging here, they have an 11% glenoid bone loss and an on-track Hill-Sachs lesion. So I think many surgeons will question whether they should have either a bony augmentation, and there are certainly many risk factors that would be very reasonable. And there are also many surgeons that would suggest that a soft tissue repair would be very reasonable for this patient. So over the next 20 minutes or so, I'll really try to cover some of what's new in instability, starting from cases where there is no bone loss to those cases when there is some subcritical or mild glenoid bone loss and bipolar defects, and then those cases sort of when there is significant glenoid bone loss and what that means and what are current treatment options for those scenarios. So let's start off with the first-time shoulder dislocation. And I think there's a lot of interest right now with a number of recent studies that have come out on this topic. And we'll do this in the context of no bone loss. So obviously it's possible to have a bony Bankart lesion with a first-time dislocation, but we'll talk about dislocations in which there are in general no bony defects. So the question that has arose is, the first-time dislocation, should they automatically go for surgery? And there's a good paper that has come out of NYU by Dr. Strauss that looked at 10 prospective studies that compared arthroscopic Bankart repair versus conservative management for the treatment of the first-time shoulder dislocation. And they found that there is a 7 times lower risk of failure with surgical treatment in comparison to conservative treatment for the first time anterior shoulder dislocation. You can see the forest plot there at the bottom left. So does that mean that every time someone dislocates their shoulder, first time, should they immediately go for surgery? Well, this is a good paper that was published by Dr. Pavola in BJSM in 2018, and they looked at 22 randomized control trials. And they also found that, yes, surgery does decrease the rate of recurrent instability, but they found that in those patients had a first-time dislocation who were treated without surgery, almost 50% did not actually have another dislocation within 2 years. So that means that if you treated every single person who had a shoulder dislocation first time with surgery, about half of them would require or would undergo an unnecessary procedure. So how can we be a little bit more thoughtful in deciding who should get surgery and who should not get surgery? So this is a paper that was published by Dr. Tokish in Sports Health in 2020, so just last year, and they developed a non-operative ISI score. And this score really tries to help the surgeon decide who is at a higher risk of failure, particularly with the young athlete. And so they identified 6 areas that you should really be looking for when you're dealing with these patients. And those patients that have 7 or more points are 12 times or more likely to fail non-operative treatment than those who have fewer points. So the things that you should be really looking out for are the type of sport, whether it's a collision sport or not, the age of the patient. Those patients that are older than 15 years are more likely to dislocate. Bone loss, if it's detectable on radiograph, the type of instability. If a patient has had a dislocation versus a subluxation, they're more likely to fail. The dominance, if it's a dominant arm versus not, and the sex. So males are more likely to fail than females. And this just a review here of the actual instability severity index score. And I use this more as a tool to really identify those risk factors. So again, those patients that have more than 6 points have a very high failure rate with Bankart repair. So their age, their type of sport participation, the type of sport, if they have laxity, and if you can see a glenoid or a Hill-Sachs lesion. So really, when you're assessing these patients, look for these factors, try to recognize them, and that will really help you in guiding your management. Now, let's move on a little bit to recurrent shoulder instability, and we'll start talking now about bone loss. And there's been a lot of research on bone loss over the last few years. So I think one of the most important concepts really is that not all bone loss is the same. And we've learned a lot about this from the track concept that was published by DiGiacomo, Itoy, and Burkhardt. And really recognizing that it is not just the presence of a bony lesion, but its size and its location as well. And so that has really brought to light bipolar consideration of bone loss. So it is not enough to just look at the glenoid and determine the treatment. You really have to be looking at the Hill-Sachs lesion, the location of the Hill-Sachs lesion on the humerus, and we'll talk a little bit more about how we are doing that, and that should really be playing an important role in your treatment. And I think the most important thing to really recognize is that bone loss is actually very common, and it is often unrecognized, and most of the time it is underestimated. And patients often will present with bipolar bone loss where individual defects are subcritical or smaller in size, and conventional treatment algorithms such as our arbitrary cutoff number of 20% should get a ladder J may not necessarily apply to these patients. And to illustrate the point about how common a glenoid bone loss is, this is a radiographic analysis study of bony defects just based on X-ray in anterior shoulder instability. And they looked at 160 patients that had dislocations, whether it was recurrent instability or anterior instability. And they found that there was a 78% prevalence of Bankart lesions or a bone loss on the glenoid, and 73% had a Hill-Sachs lesion. And another example, really, this is a CT analysis of 218 patients that had anterior shoulder dislocations. And they found in the first time dislocator, 41% actually had some glenoid lesion. And in the recurrent instability, obviously this was much higher, 86% actually had bone loss. So we know that bone loss is very prevalent. How should we actually be assessing it? What modalities should we be using? And I think really the standard of care in 2021 is a 3D CT scan looking at an on-face view of the glenoid. So this was published by the Moon Group, and really I think the 3D CT scan is the most reliable method for quantifying glenoid bone loss. Now, there is a lot of interest in 3D MRI. And so if your institution has this available, there are a number of publications that have come out recently to show that this is an accurate and reliable alternative. So if you're able to save a patient some radiation with a 3D MRI, I think that is another very reasonable option. So once you identify bone loss, how should we quantify it? So there are many different methods of quantifying bone loss, and whichever method you use, the most important thing is that you are aware of potential advantages and disadvantages of the method you are using. All of these methods are used on the 3D CT scan or 3D MRI using the on-face glenoid view. And the most common methods are diameter-based methods. So this is a simple circle that is drawn over the glenoid, and you can measure the anterior glenoid bone loss. The main concern or main disadvantage with this method is that you may actually overestimate bone loss compared with surface area methods. So that's important to take into account when you're doing your estimations. When you're looking at the surface area methods, obviously these are more accurate, but they require special software in order to be able to determine this. Now, looking at anterior shoulder instability, it's important to recognize that it's not only the baseline morphology of the glenoid. Sorry, it's important to recognize that there's also baseline morphology of the glenoid that plays a role in the instability. So if you lose a little bit of a bone loss on a flat glenoid, that is certainly more impactful than losing bone when there is a concave glenoid. And going back to the glenoid track, why is this track important? Well, this is a good paper that was also published by Dr. Tokish, and they found that 75% of patients that failed actually had off-track lesions, whereas 8% of those who failed had on-track lesions. So the track concept really plays a significant role in determining those patients that will fail or won't fail. And the glenoid track actually has also been incorporated into the ISI score. So this is a new paper that was published in 2020 that looked at the instability severity index score, and they modified it with the glenoid track. And this can sort of also help you with determining whether a patient should have a ladder J procedure versus Bankart repair. So let's move on now a little bit to subcritical bone loss and some of the new research related to that area. So we know that in patients that have significant bone loss, these patients often require glenoid bone grafting. But as we mentioned before, it's not just the presence of the bone lesion, but its size and location as well. And this really relates from the track concept. So I just wanted to go over the track concept so everybody is familiar with it. And the most important things are determining the glenoid defects and also what's called the Hill-Sachs interval. So the Hill-Sachs interval is calculated from where the infraspinatus inserts to the medial border of the Hill-Sachs lesion, and the glenoid track is calculated by multiplying the glenoid best fit circle by 0.83 and subtracting the amount of glenoid bone loss. And if the Hill-Sachs interval is greater than the glenoid track, then this lesion is considered to be off track or engaging. And if it is less than that, then it is considered to be an on-track lesion. And you can see here highlighted with the glenoid track is the area of the humerus that articulates with the glenoid as the patient brings their arm in abduction and external rotation. So There's a lot of interest in, what is critical bone loss, and traditionally we have said, more than 20 to 25% of bone loss requires bone grafting, but some recent studies by Dr. Tokish and others have really suggested that perhaps in certain populations, like military populations or in high impact athletes or combat athletes, this is actually an overestimation of the amount of bone loss. So this was an example of a study where they looked at 72 consecutive anterior shoulder instability patients that had arthroscopic labral repair, and they defined failure as recurrent dislocations. And they found that actually patients that had more than 13% or 13.5% of glenoid bone loss had unacceptable outcomes with Bankart repair. So what are our treatment options for these patients that have bipolar bone loss and some degree of subcritical bone loss or some mild bone loss? I think now we're recognizing and have recognized that Bankart repair alone is likely insufficient in these cases, and we really should be doing a Bankart plus procedure. So what does that look like? Well, I think most people would say that that would be either a Bankart repair with the addition of a remplissage procedure or some sort of bony augmentation procedure, whether it's a lateral J procedure or a free bone block procedure. And if you look at the current practice around the world, there's inconsistency. There is no sort of gold standard treatment option. So these are different survey studies that have been done of surgeons. This is a survey of the ASES group, and they found that, again, there was no consensus with how certain players should be managed when they have minimal or some mild degree of glenoid bone loss. Again, this is another survey of German orthopedic surgeons, and again, there is some variability with current practice patterns. And now both of these procedures, whether it's Bankart repair with remplissage or lateral J procedure, have some biomechanical basis to them. So this is a study by Dr. Athwal out of University of Western Ontario in London, where he looked at the remplissage procedure, and really the addition of the remplissage procedure improves shoulder stability throughout its range of motion, but you may lose some external rotation. And we'll talk about ways later on how to minimize that potential of the remplissage. What about the lateral J? Well, we're all very familiar with the lateral J procedure and the mechanism by which it works, the bony augmentation, the sling effect, and the capsular repair. So in terms of studies about the remplissage procedure, does it actually help? This is a good study that was published by Dr. Pete McDonald out of Winnipeg, where they looked at patients, and this is a randomized controlled trial with 2-year follow-up, and they found that the addition of the remplissage procedure does reduce the rate of redislocation significantly in those patients that are at higher risk. So clinically, yes, the remplissage procedure does help. So how does it compare with the lateral J procedure? This is some work that we published in Arthroscopy. Really in the mild glenoid bone loss patient, there are similar recurrent rates between the lateral J procedure and with Bankart plus remplissage. And when you look at these studies, though, these are all non-randomized trials. So there are no high-quality randomized trials comparing the optimal management of patients with subcritical or mild glenoid and bipolar bone lesions treated with either a Bankart repair with remplissage versus a lateral J procedure. So this is a study that we're doing, being led out of McMaster, that is an international trial to find out what is the optimal treatment in this patient population. So stay tuned for those results when they come out. Now, there are always complications or risks with the lateral J procedure. It is a technically demanding procedure. This is a systematic review that looked at potential complications and reoperations after this procedure, and they found that there can be up to a 30% complication rate. And I think, in the hands of someone who is skilled, obviously this complication rate is significantly lower, but there is a learning curve for this procedure. And this is another paper that we published that found that you need at least about more than 20 procedures for a surgeon to be comfortable with performing this. So if you have patients that you feel require bony augmentation, sending them to or performing them if you're comfortable, really, I think it will offer them a good treatment option. Now, just to finish off or end this talk, I'll just talk a little bit about what's going on with critical bone loss. I think right now, the majority of surgeons will perform either a lateral J procedure or a free procedure when managing patients that have critical defects. And how do these patients do? This is a paper that was again published by Dr. Hurley out of NYU, long-term outcomes of the lateral J procedure, 10-year follow-up. They found that overall return to play was about 85%, and actually 76% of patients returned to the same level of play with good to excellent outcomes in 86% of patients. And really the rate of failure after a lateral J procedure or recurrent instability is very low, around 3%. How does this compare to free bone block procedures? This was a systematic review that was performed out of Rush in Chicago, just published this year, and they found really there's no significant difference between the lateral J procedure and the free bone block in overall success with recurrent instability. So 5% versus 3% in terms of recurrent instability. So I'm just going to end this talk now describing how I perform a Bankart repair with remplissage and some technical pearls that you may feel you'd like to incorporate when you're performing this procedure. So I utilize 4 portals: an anterior portal, this high interval portal, a posterior lateral portal, and a posterior portal when performing this. I do my procedures in beach chair position, but obviously, whatever is most comfortable for you. The first thing I do is I begin with my routine diagnostic arthroscopy. I establish an anterior and a high interval portal. And I find that this high interval portal can be very useful for a number of reasons. When viewing from this portal, you have an excellent view of the anterior aspect of the glenoid, and you also have a very good view of the Hill-Sachs lesion. So all of my instability procedures, I have an anterior working portal and a viewing portal, and my initial viewing portal is this high interval portal. And so from this view here, you can see back at the back of the humerus, you have a very good view of this Hill-Sachs lesion, and you can place your anchors there, and you also have a great view of the anterior inferior glenoid. So important points here is I usually place my remplissage anchors first through my posterior portal because I have a favorable trajectory in the humerus. There's no chance of perforating the articular surface. And then I redirect my sutures through a posterior lateral portal, and that allows the sutures to come out through a more tendinous part of the infraspinatus as opposed to being at the myotendinous junction. And by doing that, you can decrease your risk of decreasing a patient's external rotation with the procedure. So I think that is technically an important point. And then I park my sutures out the posterior lateral portal. I proceed with my Bankart repair. And then on the image on the right here, you can see I then tighten my remplissage anchors at the very end of the case. And I think that's important as well, because if you tighten the remplissage at the beginning, you can over-constrain and tighten down the capsule, and it can make your Bankart repair a little bit more difficult. So to end off, I think the most important points really are recognize glenoid bone loss and humeral bone loss. The 3D CT scan is very important. Understand the importance and the role of bipolar bone lesions, and utilize the track concept when determining the treatment options. Subcritical bone loss is very common. Be on the lookout for it. Available evidence suggests that anything over 10 or 15% may be at a higher risk with soft tissue repair. And really significant bone loss should be managed with bony augmentation and that usually results in excellent outcomes. So thank you very much again for the invitation, and thanks so much.
Thank you so much, Professor Ma'in Khan from McMaster University, Canada. Thank you so much, sir, for joining us today. Thank you. I think it's morning time in Canada now.
It is.
Yeah, thank you so much, sir. if we have any questions to Professor Moin Khan. I have one question in front of me from Dr. Mustafa El Rawi to you, sir. Now, French surgeons they use the dynamic anterior stabilization techniques by using the long head of biceps as a sling effect in the 5 o'clock position, similar to lethargy without bone stock. Do you have, sir, any information about the success of this technique?
Yeah, I think it's a very interesting technique. And I think there's a lot of innovation happening with anterior shoulder instability. And there are many, many different techniques that are being published regularly. I think right now there is not that much body. There certainly are not very many comparative studies, and there are no randomized controlled trials to describe how that does in comparison to any other procedure. So really, in terms of evidence-based medicine, we don't have that much evidence right now. And certainly the most commonly performed procedures right now are still going to be the soft tissue repair or a bony augmentation. And that is those are the procedures that we have the most reliable information about and the most research about.
Yes, sir. Thank you so much, sir. If we have any questions to Professor Moin Khan? Professor Amr?
Yes.
You have any questions?
Yes, Dr. Muhammad. حضرتك سامعني؟
أي سامع حضرتك يا فندم.
I would like to ask Dr. Muhammad, in his own clinical practice, what's the cutting edge of glenoid?
Not for me.
Dr.
Professor Moin Khan.
Yes. About the cutting edge in his own practice between the critical and subcritical glenoid loss. Does he consider 20% or what's currently evolving of 13.5? Much thanks.
Yeah, I think it is
especially in young active sportsmen.
Yeah, I think it is a case-by-case basis. So in patients that are high demand or at higher risk of failure, like a contact athlete, football players, or fighters, then I will be more aggressive with proceeding with a lateral J procedure or bony augmentation, and I will use lower cutoffs, so like 13% or something like that. I would use that. In a patient that may be less demand, you know, I think it's still at 13 to 15%. I would do a soft tissue repair, but I would add remplissage procedure. So anytime I am in this subcritical bone loss or more than 10%, I'm doing what I call Bankart plus procedures, whether it is Bankart with remplissage or considering bony augmentation. And I'm more aggressive with bony augmentation if the patient is at a higher risk of failure.
Okay, thank you so much, sir. Professor Moin, your participation was an honor for me. Thank you so much, sir.
No problem. My pleasure. Thank you for having me.
Thank you so much, sir. Thank you. Now we will move to the next speaker. The next speaker will be Professor Amr Kandil from Menofia University. Professor Amr?
Yes. Okay. شير دكتور محمد.
يس اتفضل يا فندم. فول سكرين اتفضل سيادتك يا فندم.
بسم الله الرحمن الرحيم.
اتفضل يا فندم.
Much thanks for Dr. Muhammad for this nice invitation to participate in such wonderful specialty day. Our talk is about the interarticular versus extraarticular arthroscopic soft lethargy techniques in primary and revision management of glenohumeral instability. Lethargy technique remains the gold standard management option for glenohumeral instability with significant anterior glenoid loss, in addition to revision of failed arthroscopic glenohumeral soft tissue reconstructive procedures. However, lethargy procedure has been linked to a number of complications, especially glenohumeral arthropathy. Such arthritis can be explained by repeated trauma caused by pre- and post-operative recurrence of instability, in addition to operative intervention itself, especially in setting of coracoid graft malpositioning. In order to overcome these complications, Lafosse et al. Introduced arthroscopic lethargy procedure, which actually perpetuated previous complications by higher incidence of new neurovascular injury, slower renal curve, more graft and screw malpositioning, and scapular dyskinesia. Based on these complications, especially bone block-related arthritis, different arthroscopic non-bony techniques have been investigated as alternatives to lethargy procedures by gaining advantage of soft tissue structures such as conjoint tendon, subscapularis, and the long head of biceps. As regards conjoint tendon, Paulo et al. Introduced arthroscopic Bristol or belt and suspenders procedure involving transposition of conjoint tendon through subscapularis split and fixation of the conjoint tendon within glenoid bony tunnel by an interference screw. As regards subscapularis, Mayuti et al. Described tenodesis of upper third of subscapularis tendon to the anterior mid-glenoid for glenohumeral capsular deficiency. As regards the long head of biceps, there are currently evolving two different concepts on using the long head of the biceps for restoration of glenohumeral instability. The first one is dynamic anterior shoulder stabilization or DAS technique, and the other one is soft arthroscopic lethargy technique or SOLT. As regards DAS, it was described for the management of soft tissue lesion of glenohumeral instability in patients with subcritical glenoid bone loss. In this technique, the long head of the biceps is tenotomized from the superior origin, rerouted, passed within a subscap window, and fixed to the glenoid. The fixation method of the long head of the biceps to the glenoid might differ between suspension device, interference screw, or knotless anchor. As regards the use of this concept for management of a significant glenoid bone loss, in a cadaveric study, it was reported that rerouting and tenodesis of long head of the biceps to critically deficient glenoid, anteroinferior glenoid, are technically feasible, safe, and can effectively restrain glenohumeral translation. As regards the SOLT, actually these previous techniques of DAS are somewhat technically demanding, time-consuming, and costly. So for technical simplification and effective reducibility, we adopted a soft arthroscopic lethargy technique in our current practice for primary and revision management of recurrent anterior glenohumeral instability in patients with subcritical glenoid bone loss. The main technical difference of SOLT from DAS are the corridor of the rerouting of long head of biceps and the site of attachment of long head of biceps to subscapularis tendon. As in SOLT technique, the long head of the biceps is reattached to the subscapularis instead of the anterior glenoid, as in the case of DAS techniques. SOLT can be performed via two different approaches, interarticular one and extraarticular variation. Both techniques have been recently accepted for publications in a journal of arthroscopy techniques. As regards SOLT, in this technique, arthroscopic pancart repair is followed by soft tissue tenodesis of the long head of the biceps to upper border of subscapularis using two simple stitches of non-absorbable sutures. The next video demonstrates the technical steps of this technique. Is performed following pancart repair according to the next technical steps. Firstly, through anterolateral glenohumeral cannula, established 2 cm distal to the anterolateral corner of the acromion, a direct suture pattern is used to pierce the long head of the biceps just proximal to its reflection poly to deliver a loop of non-absorbable suture through the long head of the biceps. Meanwhile, through the anterior mid-glenoid cannula, a direct suture pattern is used to pierce subscap tendon at a distance of 1 to 1.5 centimeters from its superior border near its insertion into the lesser fibrosity to retrieve loop the end of the suture through the subscap tendon to the outside. Then a ring forceps is used to retrieve both free ends of the suture outside through the anterior mid-glenoid cannula. One free end of the suture is passed within the suture loop and bolts, thus driving the loop down the anterior mid-glenoid cannula, then resting tightly over the long head of the biceps. This step ends in a fixed knot, which firmly holds the long head of the biceps and subscapularis tendon to each other. This knot is further secured by 6 alternating half hitches. Similarly, another loop of non-absorbable suture is passed within the long head of the biceps in a more proximal location for a second stitch, suturing against the long head of the biceps to the upper border of subscapularis tendon while employing the previous steps. Then, the adhesion is completed by tenotomy of the long head of the biceps from the superior labrum using a combination of diathermy proof, soft tissue fighter, and integrity of soft tissue diseases of the biceps tendon to the upper border of subscapularis is checked by probing prior to closure of the border. For more demonstration, there are some case presentations. The first case is male patient of 28 years old with recurrence of anterior humeral instability of his right shoulder. MRI revealed type 5 slab lesion. Examination under anesthesia defines the direction of the instability, which was mainly anteroinferior. Arthroscopic examination revealed non-engaging heel sac lesion. So the patient was managed by arthroscopic pancreas repair using 2 suture anchors placed at 5 o'clock, then 3 o'clock position, then followed by insult technique or interarticular soft tissue diseases of long head of the biceps to upper border of the subscapularis. 10-week post-operative evaluation revealed the restoration of most of range of motion of the operated shoulder and the reestablishment of the anterior glenohumeral stability of the operated shoulder with negative speed test and O'Brien test. Another case is male patient of 33 years old with recurrence of instability of his right shoulder. MRI revealed the type 5 slab lesion. Meanwhile, the CT revealed the presence of insignificant anteroinferior glenoid bone loss. Examination under anesthesia revealed the direction of instability. Arthroscopic examination confirmed the presence of type 5 slab lesion without engaging heel sac lesion. So he was managed by arthroscopic pancreas repair in addition to diseases of long head of the biceps to upper border of subscapularis. 12-week post-operative evaluation revealed the almost restoration of normal range of motion of the operated shoulder in addition to reestablishment of anterior glenohumeral stability. A third case is a revision case of male patient of 27 years old who was managed by 21 years old who was managed by arthroscopic pancreas repair. He has a good outcome over 2 years. Then he was subjected to a trauma during a quarrel, so he has a redislocation of his right shoulder or the operated shoulder. MRI revealed the presence of the lesion in addition to a large heel sac lesion. CT confirmed the diagnosis and showed the anchors of the previous procedure. Examination under anesthesia revealed the direction of the instability and confirmed the diagnosis. So he was revised by arthroscopic soft tissue procedure. The heel sac lesion was engaging, so he was managed by remplissage. An anchor was placed in the heel sac lesion. Sutures were passed through the infraspinatus tendon and left without tying till the end of the procedure. Then the capsulolabral complex was released, reduced back to its footprint, and repaired by 2 suture anchors. This technique of release wasn't an easy task because of the extensive adhesions and fibrosis and poor elasticity of the capsulolabral complex. However, by the end, it was feasible to repair the capsulolabral complex by 2 suture anchors. This procedure or this pancreas repair was coupled by soft tissue tendinitis of long head of the biceps to the upper border of subscapularis using 2 simple stitches of non-absorbable sutures, then tenotomy. Eventually, remplissage was then, after checking the integrity of this anterior soft tissue repair, remplissage was then completed by not tying of sutures of the anchor placed in the heel sac lesion. 12-week post-operative evaluation revealed the almost restoration of normal range of motion and reestablishment of the anterior glenohumeral stability with negative speed test of the operated shoulder compared to the contralateral one. As regards the other technical variation of soft arthroscopic lateralogy technique, which can be performed through extra-articular approach, in this technique, prior to arthroscopic pancreas repair, long head of the biceps is retrieved to the subpectoral region following its interarticular tenotomy, web-stitched, rerouted deep to the pectoralis major, and passed within subscapularis into the glenohumeral joint, where it's sutured over itself around upper subscapularis tendon. Extra-articular soft arthroscopic lateralogy is performed according to the following steps. Anatomic landmarks are initially through a 5 centimeter incision centered at the crossing point of lower border of the pectoralis major and the anteromedial border of the arch subcutaneous tissue is dissected to expose the fascia covering the pectoralis major. This fascia is then swept off by coated bond to facilitate visualization of lower border of the pectoralis major. Anteromedial side of upper arch is explored by blunt dissection till identification of long-headed biceps tendon, which can be stitched at the level of the lower border of the pectoralis major by absorbable suture. Under arthroscopic visualization, and tenotomy of long-headed biceps is performed afterwards. Long-headed biceps tendon is pulled out from under the cover of the pectoralis major. Three ends of long-headed biceps tendon is trimmed off and will be stitched by a couple of number 2 non-absorbable sutures of different colors over a length of 1 centimeter for each suture, with an intervening with a stitch free distance of 1 centimeter. Following the removal of the anterior mid-glenoid cannula, into the finger is passed deep to the pectoralis major towards the anterior mid-glenoid fossa to establish a subpectoral tract to facilitate passage of an arthroscopic blunt trooper and sheath deep to the lower border of the pectoralis major to appear through the anterior mid-glenoid fossa. Arthroscopic trocar is removed from its sheath, through which a circling suture is passed to appear deep to the pectoralis major. The arthroscopic sheath is then removed, and the sharpened suture is fed to the web-stitching suture and pulled out of the anterior mid-glenoid fossa in order to deliver the long head of biceps tendon out of the anterior mid-glenoid fossa. Thereafter, at a distance of 1 centimeter from its upper border and about 2 centimeters from its insertion into the lateral velocity, subscap tendon is used under arthroscopic visualization by a sharp, long, straight artery clamp or by an arthroscopic sharp trocar, creating a subscap hole which can be widened by motorized shiver blade into a subscap window or slit of about 1 to 1.5 centimeters in length. Then, an arthroscopic ring forceps is used to pass the web-stitching suture through the anterior mid-glenoid cannula from its articular to the diaphragm opening. Then the cannula is placed back into its corresponding fossa. Using an arthroscopic ring forceps or suture transfer, 3 ends of the proximal web-stitching suture are passed through the subscap window to be delivered behind the subscapularis. An arthroscopic ring forceps is then used to retrieve the delivered sutures over the subscap tendon and then out of the anterior mid-glenoid cannula. Retrieved sutures are pulled until web-stitched long head of biceps tendon is shuffled through subscap window into the glenohumeral joint. Next, a limb of retrieved proximal web-stitching suture is tied to a web-stitching suture, and the knot is forced down the cannula by a knot pusher still resting over the long head of the biceps tendon. Knot tying eventually results in suturing the web-stitched end of long head of biceps tendon over itself around 1 centimeter top of upper border of subscap tendon. Integrity of soft tissue diseases is checked by probing axial loading of long head of biceps tendon and by propagated 90-90 glenohumeral position. There are some case presentation employing the technique of EXALT, as in this case of revision of female patient of 29 years old who had previous open transosseous pancreas repair at another institution about 10 years earlier. 2 years following the procedure, she had the recurrence of dislocation or instability of her right shoulder, and remained and developed about maybe 25, 26 episodes of instability or frank dislocation. The MRI revealed the type 5 slab lesion, and examination under anesthesia confirmed the instability. Arthroscopic examination revealed the presence of type 5 slab lesion, including both anterior superior and posterior superior labrum, in addition to pancreas lesion stretching out of the capsule, glenohumeral capsule, in addition to non-engaging heel sac lesion. Engagement of the heel sac lesion over the anterior glenoid occurred mainly by the end of by extreme range of motion positioning. So the patient was managed by EXALT, in which the biceps tendon is tenotomized, rerouted deep to the subpectoralis or the pectoralis major, passed within subscap tendon and stenosis to the subscapularis, followed by arthroscopic pancreas repair, and finally the whole construct was dynamically tested. Another case of a revision of instability is a male patient of 29 years old with left-sided failure of arthroscopic repair of a slab lesion. Examination confirmed the diagnosis of anterior glenohumeral instability. Arthroscopic evaluation showed type 5 slab lesion in addition to pancreas lesion and stretching out of the glenohumeral capsule. Probing showed the arthroscopic failure of slab lesion repair with the poor soft tissue quality of the labrum. These sutures of previous anchors were removed by a suture fighter or soft tissue fighter, and the patient was managed by EXALT, in which biceps tendon was rerouted to subscap and passed to the anterior mid glenoid portal. In such case, we modified the technique of EXALT. Instead of passing the biceps tendon through a subscap window, the long head of biceps tendon was sutured to the anterior aspect of the subscapularis using absorbable and non-absorbable sutures, instead of passing the long head of the biceps through a subscap split, and this was followed by arthroscopic pancreas repair in standard fashion. An advantage of EXALT technique is its versatility, so it can be coupled with other procedures, as in this case of a male patient of 39 years old with trauma to his right shoulder followed by acute shoulder dislocation, and MRI of his right shoulder revealed the presence of massive retracted rotator cuff tear, in addition to signs of labral lesion. He was managed by EXALT, biceps tendon harvested, fashioned, rerouted, and passed within a subscap tendon. Then this was followed by mini open repair of the rotator cuff due to insurance and cost issues. And finally, the whole construct was tested under dynamic conditions, especially in provocative positions for anterior glenohumeral dislocation in extreme positions of abduction external rotation. Another case, or fourth case, is a male patient of 60 years old who has trauma to his right shoulder 2 years ago, and on top of this trauma, he had a dislocation of his right shoulder with massive retracted rotator cuff tear. He was managed at another institution, and he was managed by arthroscopic pancreas repair instead of rotator cuff repair. by 6 or maybe 4 months post-operatively, he started to develop a redislocation of his operated shoulder. He presented 2 years before to our institution. By this time, he has a good range of motion, but he has might be a pain by mid-range pain, might be due to the superior scape of the humeral head, or maybe due to the mid-range instability. In addition, there was a history of a recurrence of instability of about 8 up to 10 times of redislocation. MRI revealed the presence of a repairable massive retracted rotator cuff tear, in addition to the ankles used for therapy. Examination under anesthesia confirmed the diagnosis. So he was managed by Exalt with trapezius tendon transfer, harvesting tendon, hamstring tendons was harvested and fashioned as a sheet. Through McKenzie approach, the joint was debrided and sutures were removed. Then long head of biceps rerouted to the subscapularis. In such case, the subscapularis was torn, so it was repaired by an anchor, anatomically repaired by an anchor. Then the tendon of long head of biceps was passed through a subscap window and sutured over itself around the upper border of subscapularis. Rotator cuff was partially repaired by 2 suture anchors, and the part of the head was left uncovered. Then the trapezius tendon of the trapezius was harvested, released, and tested for excursion. Then the hamstring sheet was passed through a subacromial subtrapezius corridor from the humeral side to the scapular side. On the humeral side, the sheet was sutured to the footprint of the rotator cuff and to the repaired cuff, including the subscapularis and the infraspinatus. Then on the scapular side, the sheet was sutured to the release tendon of the trapezius by non-absorbable sutures, while the scapula is retracted and the glenohumeral joint in 45 degrees of abduction external rotation, and eventually the whole construct was dynamically assessed for integrity of the rotator of the tendon transfer and for the integrity of the exalt or soft tissue reduced of long head of the biceps to subscapularis. When comparing the currently reported techniques with letter J, these techniques of insult and exalt can offer 3 out of 4 of 4 glenohumeral stabilization mechanisms of letter J, including sling effect, increased tension within subscap fibers, and concurrent capsulolabral repair. However, these techniques don't restore the bony glenoid. However, normal glenoid articular concavity could be partially restored by these techniques by concurrent capsulolabral repair. In addition, the bony glenoid reconstruction offered by lateral J procedure is effective mainly in early range of motion, which is not the brocated position of for glenohumeral dislocation in most of cases. This is supported by a cadaveric study of stabilizing mechanism of lateral J procedure by Yamamoto et al., which revealed that the bony factor of lateral J procedure is responsible for about 45% of glenohumeral restabilization, mainly in early range of motion. Currently reported technique might have the following advantage, as they can be employed in different glenohumeral instability conditions such as type 5 sublesion, poor soft tissue quality of the antero-inferior capsulolabral complex, and the revision management of glenohumeral instability. There are no complications related to coracoid graft harvest, transfer, or fixation. No significant limitation of range of motion, especially of external rotation, is expected. They can be performed via arthroscopic and minimally invasive approaches, in addition to technical safety, technical reproducibility. Also, in contrast to other techniques of death, ankle repair is not hindered by the disease of long head of biceps to subscapularis. No hardware is used, and when or if these techniques fail, revision surgery would be relatively easier. Disadvantage of these techniques include they are non-anatomic and may interfere with force-couple mechanism of two heads of biceps as described by Etoy et al. In addition, pupille deformity is a possibility due to failure of tendons. In conclusion, for primary and revision management of glenohumeral instability, preliminary outcomes of currently reported techniques of soft tissue tendinosis of long head of biceps to upper subscapularis in concurrence with pancreas repair are favorable. However, these techniques should be investigated in further biomechanical and cohort clinical studies in order to clarify their long-term validity. Much thanks.
Thank you so much, Professor Amr Andil from Monofea University, for this very interesting talk. Thank you so much, sir. We have a question for you, sir, from Dr. Beha Saeed. Why we tenodesis the biceps tendon to the subscapularis tendon instead of direct tenodesis to the anterior labrum to augment?
Yeah, okay. As regards as an indication, type 5 slab lesion, we have to address the slab lesion. Slab repair, even in young age, is usually complicated by limitation of external range of motion, of external rotation, in addition to post-operative pain, first point. Second is, so the tendency now is towards to tenodesis, and when we compare other techniques or conventional tenodesis using hardware such as suture anchors or interference screw with soft tissue tenodesis, post-operative pain is much less. In addition to avoiding this pain and limitation of range of motion, we can have the advantage of using the long head of the biceps as a sling or a modified sling to increase stability. In addition, it can increase the tension of the subscapularis, so it can add it in restabilization of the glenohumeral joint.
Yes, sir. Thank you so much. If we have any other questions to Professor Amr? Okay, thank you so much, sir. شكرا جزيلا دكتور عمرو بيه. اخر حاجه ان شاء الله في الشولدر سبيشاليتي دايز هيبقى معانا ريكوردد سيرجري اللي حاولنا نعرضها امبارح بس كان في تكنيكال بروبلم وبنعتذر عنها. هيبقى عليها تعليق من استاذ الدكتور حسام البيجاوي بروفيسور اوف شولدر اند ني سيرجري بنها يونيفرسيتي. هي اوفرد من زمر كامباني. دكتور حسام بيه هيعمل كومنت عليها وهنعرض الفيديو ان شاء الله. دكتور حسام بيه اتفضل يا فندم.
السلام عليكم يا دكتور محمد.
السلام الله وبركاته يا فندم.
السلام عليكم كل زملائنا وكل اساتذتنا. كل سنه حضراتكم طيبين واهلا ومرحبا بكم في الشولدر ارثروسكوبي شولدر كورس. هو المحاضره ديت المفروض ان هي شولدر ارثروبلاستي. المفروض ان هي بدل اللايف سيرجري هتكون يعني احنا جايبينها من شركه زمر بدل اللايف سيرجري. فاحنا بس قبل ما نبدا المحاضره او قبل ما نبدا نتفرج على الفيديو، عايزين بس ان انا اقول انبه بس ان هي ديت بدل يعني موجهه لطلبه الماجستير والدكتوراه، لان هم بيمتحنوا في الشولدر وفي الابروتشز والحاجات دي. ففي تكنيكال بوينتس المفروض ان هم ياخدوا بالهم منها، احنا المفروض ان احنا نعرفهم بيها. اولها اللاند مارك في الابروتش، اليوز اوف ريتراكتورز، وبعد كده البروسيدور نفسها بتاع الارثروبلاستي، ازاي نظبط ناخد الكاتس بتاعتنا، وازاي نظبط الانتي فيرجن، و هاو تو يوز ترايلز والسيمنتيشن، وبعد كده البوست اوبراتيف مانجمنت. فنبدا نبدا يا حسام او محمد شاهين او محمد، نبدا الفيديو واحنا ماشيين كده ان شاء الله هنعلق عليه. وطبعا شركه زيمر كانت سبورتيف جدا في الكورس بتاع بنها يونيفرستي. اتفضل.
Seen by this AP X-ray, there's a large inferior osteophyte as well as glenoid osteophyte, but the rotator cuff tissue is intact. It is important to also get an axillary view. What the axillary view does is it allows you to see the amount of glenoid wear, and this patient had a small amount of glenoid wear with posterior subluxation of the head. In addition, it allows you to evaluate the glenoid wall where the glenoid pegs or keel will fit. So these are two essential x-rays. If, in fact, an adequate axillary x-ray cannot be achieved, then a CAT scan or an MRI is essential to be able to assess the glenoid. In marking the skin, the coracoid is marked, and that allows you to place an incision just lateral to the coracoid, and it starts at the clavicle, which is at this position. So we'll go from the clavicle to an area of the mid-humerus. That's an extensile exposure, which will allow for you to have a full exposure of the entire glenohumeral joint. Smaller exposures can be used, but will require more retraction. This long deltopectoral approach, even though there's a large skin incision, preserves muscle attachments as the deltoid origin is not removed.
ده الدلتوبكتورال ابروتش. زي ما انتم شايفين الانسيجن واخد اللاند ماركس.
Begin the skin incision at the clavicle, extended on the lateral side of the coracoid process and down to the area of the mid-humerus. Use electrocautery to incise the subcutaneous tissue from the deltoid fascia. Expose the deltoid and pectoralis major muscles. Retract the skin by placing large Gelby retractors about 1/3 of the way down and 1/3 of the way up. Develop the deltopectoral interval. Retract the pectoralis major muscle medially and the deltoid muscle laterally.
There's a fair amount of adipose tissue in this patient, and sometimes it's very useful to just put your finger in and shift the
هناخد بالنا من السفالك فين بعد كده هو هياخده
stiff joints.
ميديالي ولا لاترالي.
Deltopectoral interval is usually medially retracted.
Attach a self-retaining retractor with 2 retractors under the skin on the medial side and 1 on the lateral side. Then identify and dissect the interval between the pectoralis major muscle and the cephalic vein.
Right now I'm trying to find the interval for the cephalic vein. It's usually where the fat is. You can see that there's a fat area here. Here's deltoid. Here is pectoralis major. Here's the pectoralis major coming in. Here's the shaft. And I'm just clearing away some of the adipose tissue from the interval and the area of the pec major. Here is the top edge of the pectoralis major here. The cephalic vein is just lateral. Right now,
واخد
I've got
السفالك
my
فين لاترال.
roof of the pectoralis major dissected, and I'm just going to try to separate it from the cephalic vein. Right in this area here. Here are the fibers, and here is our insertion. The cephalic vein is right in this position here. We can see it right here. I'm just bringing the area up. Right here is the insertion of the pectoralis major. And I think that the option here is to either remove it to increase exposure, which we will do, or you could leave it in, but it limits your exposure to the glenohumeral joint. It creates even more contraction. So I think the case could be done a great deal quicker if this tendon is removed and tagged and reattached at the end of the case. I'm just taking off the insertion of the pectoralis major. And the important thing here is to miss the long head of the biceps, which is right underneath it.
نعمل ريليز للسبسكابيلاريس. Just
Connect
lateral
the pectoralis major muscle with a suture to identify it for later reattachment. Reposition the distal medial retractor under the pectoralis major muscle. To further improve the exposure, release the tissues under the strap muscles all the way to the coracoacromial ligament. Reposition the proximal medial retractor under the coracoid muscle. Sweep the bursa off the humeral head and the greater tuberosity. Expose the superior portion of the glenohumeral joint.
Sometimes it's very good to get the leading edge of the coracoacromial ligament, as you can see that I've got right here. And I can take the cautery and just develop this across.
بيعمل ريليز للصبل الكروكوعكروميال ليجامنت.
Dissect the entire subscapularis tendon laterally and the capsule beginning just medial to the long head of the biceps tendon. Extend this dissection superiorly to find the superior aspect of the subscapularis tendon. It is very important to maintain as much length of the subscapularis as possible. Tag the superior end of the subscapularis tendon with a suture.
ياخد فيها
Then
space section.
continue to dissect the inferior portion of the subscapularis tendon.
It can be helpful sometimes in this position to take an elevator and go right inside the joint. As you can see right here, it kind of falls away.
بعد كده
This helps
dislocation.
with retraction.
Use the elevator to dislocate the humeral head.
This patient has a significant amount of articular deformity to the humeral head, so it will be a challenge for us to make the right cuts in the head. But the landmarks that we're interested in are number one, the biceps tendon right here. Here's the bicipital groove that we can see. And number two, we want to see the neck of the humerus, which we can't see very well because of the fact that there's osteophyte. So there's very prominent osteophyte. The first maneuver is to take osteophyte off with a rongeur. And take this off. We can then find the true neck. And as you can see, the cut that I made here allows me to see where the neck is and where the
Removes
true
the
bone is
sequence.
down into this position. So it'll allow me to make a much more accurate cut.
يبدأ بالhumeral head preparation.
Attach the appropriate size short reamer with a trocar point to the ratcheting T-handle. There are three positions marked on the collar of the T-handle: forward, locked, and reverse. To ream the starter hole, use the forward position. Place the trocar tip of the reamer just posterior to the bicipital groove. Ream a starter hole in the bone.
Point of entry.
A mallet may be used to start the hole in hard bone. Then attach the T-handle to the longer, blunt-tipped intramedullary reamer of the same diameter. Begin reaming manually and use progressively larger reamers in 1 millimeter increments until resistance is felt from cortical contact in the canal. Continue reaming to the appropriate depth as indicated on the reamer shaft. The depth corresponds to the implant length chosen. Do not remove cortical bone. Remove the T-handle, but leave the last reamer in the canal.
The circumference of the reamer is smaller distally and larger proximally, just like the shaft of the humerus, so that it will not cause an uneven grinding or wearing of the inside part of the humeral cortex when the reaming is done.
Assemble the humeral head cutting guide for either a right or left configuration. Align the groove on the boom stem with the groove on the cutting block. Push the components together until they snap into place. With the thumb screw at the end of the boom pointed toward you, observe the various R and L etchings that indicate a right or left configuration. All the etchings facing you now should be the same, either R or L. To change the right-left orientation, remove the thumb screw at the end of the boom. Then loosen the second thumb screw on the box at the top of the boom stem. Slide the boom stem off the end of the boom. Rotate the sleeve toward you, top to bottom, and reinsert it from the opposite side into the box at the top of the boom stem. Retighten the thumb screw on the box at the top of the boom stem. Then reinsert and tighten the thumb screw at the end of the boom. Finally, verify that all the appropriate right or left etch marks are visible when the boom thumb screw is facing you.
Humeral guide will allow the appropriate amount of retroversion. The centering point, once again, is based on this tip of the guide, which will be centered at the posterior aspect of the bicipital groove. By centering it here, this will allow us to do a very articular-minded level cut that will assure the proper degrees of retroversion, meaning that our cut will be along the articular surface of the humerus, regardless of the amount of deformity.
Slide the boom sleeve over the reamer shaft. Adjust the depth of cut by moving the sleeve up or down on the reamer shaft. Rotate the sleeve on the reamer shaft until the point is approximately in line with the bicipital groove. Then tighten the thumb screw on the end of the boom. Advance the boom stem and cutting block along the boom until the block contacts the bone, and tighten the second thumb screw, which is located at the junction of the boom and boom stem. Insert alignment pins into the holes marked 20 degrees and 40 degrees on either the cutting block or boom sleeve. To gauge the retroversion of the cut, line the pins up with the forearm. The forearm should be between the 20-degree and 40-degree pins. Insert the humeral head cutting guide fingers into the cutting slots to visualize the path of the saw blade through the bone. If necessary, loosen the thumb screw at the end of the boom and adjust the depth of cut. Partially insert a cutting guide pin through one of the lateral holes in the cutting block. Fully insert a second pin through one of the medial holes. If the cortex is very hard, pre-drill these holes using a drill with a diameter between 2 millimeters and 2.7 millimeters. Loosen both thumb screws on the boom sleeve. Remove the boom sleeve, reamer, and alignment pins.
A narrow retractor can be used to protect also the medial structures here and create some retraction. And metal finger can also be used to get the retraction posterior. But we can see here that the guide here, these guide pins protect the rotator cuff.
Using the top of the cutting block as a guide, resect the humeral head with an oscillating saw. Remove the humeral head cutting guide. Be sure that the white plastic cap on the humeral inserter extractor is tight. Then attach the inserter extractor to the appropriate size stem provisional.
This humeral insertion device attaches to the humeral prosthesis in the line of the shaft, which really facilitates maneuvering the humeral prosthesis of the bone. It helps with removal as well as with insertion. It is screwed into place here. There are guide holes, 20 and 40 degrees of retroversion to be able to check the relative retroversion.
Insert the stem provisional into the humeral canal. Impact it with a mallet until the collar is flush with the cut surface. The fins on the provisional are self-cutting to prepare a path for the fins on the stem implant. Then remove the inserter extractor.
The offset is in the shaft has been medialized 2 more millimeters, so we don't have superior positioning of the head. Also, we have the offset option, which will allow us to anatomically place the head in the proper position.
Use a curette to remove any bone from the center hole of the stem provisional. This will allow for later placement of the provisional head. Attach the provisional humeral head. If using an offset head, rotate the head into the proper anatomical position. Mark the position of the head on the bone at the etched line labeled max.
زي ما قلنا use
Reduce
of
the joint
trials.
and perform a trial read.
The other thing I like to do, Richardson right here, is at this point, because it really allows you to see how much of a how the sizing goes, is to externally rotate, and that's very stable at 60 degrees. and internally rotate. That's very stable in internal rotation. The other trick that can be done now is to take a retractor, please. Put it underneath this position, and then see how tight the subscapularis is. And right here, we can see that the subscapularis is a little tight, Tevdek. But it will be further released. But the good news is that the subscapularis comes over quite easily, which is another clue to me that we've got the right size head in position. See that right here, neutral and a little bit of external rotation. The subscap is almost all the way back.
After the trial reduction, remove the provisional head.
It's very important to leave the humeral trial stem in place, as this will hopefully decrease bleeding and also protect the cortex of the humerus.
Retract the soft tissues both anteriorly and posteriorly to expose the glenoid.
An important issue at this point is the subscapularis, which needs to be freed up superficially immediately, as I'm doing here. It's important to go underneath the coracoid, and this can be done either now or a little bit later, but that will facilitate exposure and also allow us to laterally mobilize the subscapularis. One of the problems that you have is in this position where there's capsule completely binding down the subscapularis, which will come out to length. So it is important to be able to dissect capsule off the subscapularis without significantly injuring the muscle or the axillary nerve, which is in this position. So before we can put a retractor in anterior, we need to remove some of this hypertrophied synovium. This can be done either with a cautery or scissors. The cautery allows you to maintain hemostasis. And I sometimes will stop short right here of the labrum so that we don't injure stability, but I'm peeling the capsule right here off the subscapularis, which will allow me to gain length to the muscle and also allow me to gain strength to the muscle, as what this will do is it will take away the adhesions and the scarring. So I have not completely removed the labrum, however.
Retract the remaining soft tissue immediately. Use the glenoid scraper and glenoid planer to remove any remaining cartilage and soft tissue from the glenoid. Apply the glenoid centering guide over the glenoid. This will help determine the proper size to use, as the outer dimensions of the guide match the articular profile of the glenoid implant. Use the glenoid drill with stop through the glenoid centering guide to drill a centering hole through the subchondral bone of the articular surface. Attach the appropriate glenoid circuit, angle driver, or straight driver. Glenoid spoke reamers are available in order to more aggressively ream the glenoid face. These reamers feature 5 straight open spokes, allowing the removed bone to funnel through the reamer. They are joined by a threaded connection to either the angled or straight driver. Insert the nose of the reamer into the centering hole and use the T-handle to ream the glenoid. Apply the appropriate sized keeled or pegged glenoid drill guide by inserting the nose into the centering hole. For this surgery, a keeled drill guide will be used. Then drill the second and third holes through the guide. An anti-rotation pin may be placed in the second hole to stabilize the guide while drilling the third hole. Apply the keeled glenoid slot guide to the articular surface. Use a 5mm high-speed burr to create a vertical slot in the subchondral bone of the articular surface. Use the keeled glenoid sizer pressurizer to impact the remaining bone in the slot. This will help ensure an appropriate internal depth and diameter to accept the keel of the glenoid component. Insert the keel locator on the glenoid circular reamer into the slot and use the T-handle to ream the glenoid. This may be necessary to help facilitate the fit or to fine-tune the version of the glenoid component. Attach the keeled glenoid provisional component to the glenoid inserter. Insert the keeled glenoid provisional component into the prepared slot and perform another trial reduction. After removing the provisional components, insert a thrombin-soaked keel sponge into the glenoid slot to promote hemostasis while mixing the cement. When the cement is ready, remove the thrombin-soaked sponge and use a 60 cc syringe to inject cement into the keel slot. Cement should be injected early in the working time to facilitate pressurization into the cancellous bone bed. Attach 2 pressurizer sponges to the glenoid sizer pressurizer and pressurize the cement. Inject additional cement. Then remove the top sponge from the pressurizer and pressurize again. Then fill the remainder of the glenoid vault with cement, being careful that no cement is applied to the surface of the glenoid. Attach the final glenoid component to the glenoid inserter. Insert the glenoid component and press it firmly into place. Then use the glenoid pusher to impact the component until there is complete contact with the perimeter bone. Maintain pressure on the component until the cement is hardened. Be sure the pressure remains centralized. When the cement is hardened, remove the retractors.
I think it's important to put your finger or a bone hook here so that the humerus doesn't touch the glenoid as you come out. And I usually like to put my finger in that position. And if someone put a Richardson over the deltoid, a bone hook can be used also in this position in very tight situations. Gently pull with a bone hook. That allows you to be able to pull the humerus, clear the humerus past the glenoid without any impingement.
Attach the humeral inserter extractor into the provisional humeral stem component. Turn the barrel to secure the instrument to the provisional. Pull the provisional out of the humeral canal. Assemble the stem collar counterbore using the appropriate size of stem extension to match the stem diameter chosen. Attach the straight driver to the counterbore. Insert the stem extension of the counterbore into the humeral canal. Turn the T-handle to countersink the resected surface of the proximal humerus. The countersink depth of cut is limited and the counterbore will bottom out. Attach the stem provisional to the humeral inserter extractor. Reinsert the stem provisional into the canal and remove the insertion instrument by loosening the screw barrel. Check to ensure that the provisional component is completely countersunk. Snap on the appropriate size provisional head. Reduce the joint and check the fit. Pull the subscapularis muscle over the joint. If the fit is too tight, release the fibers as needed. Remove the provisional components and perform any necessary soft tissue releases. Drill 4 or 5 suture holes through the anterior neck of the proximal humerus. Insert heavy nylon sutures through the holes for reattachment of the subscapularis tendon and muscle. Insert canal sizers to determine the appropriate size cement restrictor plug. Insert the plug into the canal 1 centimeter distal to the tip of the humeral stem. Then thoroughly clean and dry the canal. Inject bone cement into the humeral canal. Use a finger to thoroughly pack the cement.
لاحظوا الانجكشن بتاع السيمنت without pressure.
One of the holes is the white plastic cap on the humeral inserter extractor. Attach the final humeral stem component to the inserter extractor. Tighten the barrel. Insert the distal tip of the component into the canal. Insert the 2 alignment pins into the 20-degree and 40-degree holes of the inserter extractor and check retroversion.
الانتي فيرجن
When properly
بتظبط ليه
aligned, Fully insert the stem into the canal.
2 pins.
Remove the alignment pins and impact the component with a few light taps of the mallet. Be sure that the collar of the component is seated flush on the cut surface of the humerus. Remove the inserter extractor. When the cement has hardened, thoroughly clean the neck of the humeral stem. Mark the position of the humeral head as determined earlier in the trial reduction. In this case, the head will be positioned with the maximum overhang at approximately 2 o'clock. Attach the final offset humeral head component to the offset humeral head inserter, so the single prong is positioned at the max or previously marked indication. Insert the final humeral head component so the single prong is at the mark made earlier. Apply the head pusher to the head and impact it with the mallet. Check to ensure that the head is firmly attached. Then reduce the joint and check stability. Beginning inferiorly, reattach the subscapularis muscle to the sutures at the rim of the proximal humerus. Insert a hemovac wound drainage device, being careful to avoid the axillary nerve. Then close the deltoid and the subcutaneous layers, being careful to avoid the cephalic vein. Finally, close the skin.
From inferior to superior, and then close the skin.
Post-operative x-rays reveal a successful surgery.
In the post-operative period, a patient with osteoarthritis will be started on passive assisted range of motion on post-operative day number 1. This involves pendulum exercises, assisted forward elevation, erect and supine, as well as external rotation with the stick supine. Patients generally discharged between the 2nd and 4th post-operative day, and exercises are maintained as an outpatient. Hopefully, within the very short period of time, 140 of elevation, forward elevation, and 40 of external rotation are achieved. Active exercises are generally started between 1 and 2 weeks, depending on the pathology. The only muscle that has really been cut is the subscapularis, so active internal rotation is avoided. Patient is progressed to the 6-week period of time, after which time more resistive strengthening exercises are started. Emphasis is on stretching, balancing the range of motion, and strengthening is a secondary concern, which is achieved months post-op.
شكرا جزيلا، شكرا لشركة زمر على الفيديو. وده يا ريت يكون الطلبة شافوا الكلام ده بحيث ان هم يعرفوا يكونوا عرفوا الابروتش ازاي، واللاند ماركس بتبدا ازاي، والسكشن ازاي لحد الكلوجر والبوست اوبراتيف مانجمنت. شاكرين جدا.
شكرا جزيلا دكتور حسام بيه، شاكرين جدا على تعبك معانا. يعني في نهايه اليومين الجمال دول انا طبعا I would like to thank all our eminent guest speakers من مصر ومن كندا ومن انجلترا ومن البرازيل على وجودهم، ومن سويسرا على وجودهم معانا في اليومين دول. الحمد لله بتوفيق الله سبحانه وتعالى وبمشاركه اساتذتنا الاعزاء الكرام الافاضل. اليومين دول عدوا على اجمل ما يكون من فضل الله سبحانه وتعالى. ان شاء الله نوعد حضراتكم النكست سبيشاليتي دايز ان شاء الله باذن الله تعالى، يعني هتبقى ان شاء الله بعد 3 اسابيع. انا بحاول لان انا يعني يعلم الله سبحانه وتعالى يعني مشغولياتي قد ايه من ساعه ما مسكت العميد، بس ان شاء الله بامر الله يعني مستمرين باذن الله تعالى ان شاء الله. ان شاء الله النكست سبيشاليتي دايز هتبقى هيب سبيشاليتي دايز، ودي تخصصي بقى. فان شاء الله هنجيب يعني كولكشن من مصر وانجلترا وكندا وامريكا يعني ان شاء الله هنحاول نجيب من كل مكان في العالم ان شاء الله. ان شاء الله في غضون 3 اسابيع هيبقى الهيب سبيشاليتي دايز ان شاء الله. فان شاء الله نسعد برؤيه حضراتكم يا فندم. متشكرين دكتور عمرو بيه، متشكرين دكتور حسام، استاذنا الدكتور ماهر بيه عسال، كل اساتذتنا الكرام الافاضل اللي شاركونا. كل عام وحضراتكم بألف خير، ومتشكرين جدا على وجود حضراتكم معانا في اليومين الجمال دول. شكرا جزيلا.
شكرا دكتور
وجزاكم
عام.
الله كل خير يا استاذنا.
شكرا
شكرا يا فندم.
شكرا
شكرا يا فندم. شكرا يا دكتور حسام. شكرا يا عمرو بيه. شكرا يا فندم.
شكرا
شكرا يا فندم.